Yes, it goes all the way up to 18. And that printer, Tashiana, did you see what's her name yesterday? Kara? Yep. Okay, good. There's more printing on that printer over there. It needed
Is it
paper.
over there?
10 is over here.
Oh, okay.
Okay. Did you guys get my email about coming to campus to North Canton? Okay. A couple people wanted to come here, and I talked to Dr. Bowling last night about it. And so depending on if it is an exam day, we are going to have to talk to your ADON and just make sure we know who is going where, and just double check that everything is okay. If it's just a regular day like today, or a regular day within the week that doesn't involve an exam, whoever wants to come here is perfectly totally allowed to. I have 7 open computers, but I also have a ton more chairs. So if you do come, just please let me know, and then come prepared and bring your laptop. And I just need to know, like, morning of, at least, like, who's coming. Okay. So
Is
if
that
there's
something you suggest we do?
No. It was brought to my somebody asked yesterday, and I had a couple of people from Niles, and I think one of the girls from Illyria had asked. So it's not necessary at all in any way, shape, or form. But like Niles is an hour away, Illyria is I think a little less than an hour. So, and some of them already drive, an extended period of time to get to campus. So they were just kind of seeing if it was even a possibility if they could come here for lecture. So it's truly completely and totally up to the people that were wondering if they could do that. It is absolutely not a requirement. It is only a requirement of people that are North Canton students, because they have to be on campus. So can you send me something to say that you're interested, or you're thinking about it, or something? Okay. I don't know why the recording from yesterday is taking so long to process. It does not usually take this long. Am I breaking up for anybody else? No.
No, I can hear you good.
Okay, because I'm already on my hotspot. But as soon as the video is done processing, I will have it sent out to you. It will go into our group email, and it'll literally just be a video that you click play and it'll play. So, yeah, so as soon as that is ready, I will send it out. I see 39. That means I'm missing people. If you are here, please put a I'm here in the chat, so I don't have to go out and call every single name individually, because there's 40 of you and I don't want to do that. Perfect. Thank you. It's easier for me to figure out who's missing when you guys do that. Awesome. So we're going to start with chapter 44, because that's where we left off yesterday. Perfect, perfect, perfect. All right. Okay. So how is everybody today? It seems like almost everyone got access to their Lippincott. I talked to, I think, one person this morning. Your access is being worked on as we speak. Is anybody else having an issue with Lippincott or API still?
I
If
still
so,
am.
okay, which one?
Desiree.
No, I know which.
Oh.
API. Okay.
Lippincott.
Okay. Just send me an email.
Okay.
So I can keep track of all the people that still are having an issue with Lippincott and or ATI, and please specify which one so that we can get it fixed today.
Okay.
I know that Justin is working diligently to get everybody's done. I just sent him another email this morning for Tiffany. So whoever else needs that, please let me know. Like I said, I do not want you guys emailing Justin and like bombarding him with emails. I would rather just send him one list, which I did yesterday, and he is currently working on that list. So if you got access, that means that he's working on it. And I know just by looking at Brightspace and all the things that were uploaded that a lot of you did get access. So that's awesome. Okay. So much thing. So I'm assuming at least one of you already had everything printed? 1, 2. Okay. So we have 2 extra of everything. Okay. We're just going to make sure we recycle. Because that's the only way that Jessica can deal with overconsumption of paper, is that we use our shredder bins and we recycle. I don't know why, but I care a lot about the trees. I don't know. I think it was I was born in the 90s and it was like drilled into us to recycle everything. So okay. We're just gonna wait for Tatiana, I guess. Why the long faces? What's up? I feel like are we in a mood? Are we okay? What's up?
I think life is just lifing.
Life is lifing?
Yeah.
I feel like I thought I was going to be like ahead of the game because this is a repeat for me, but it feels like so much new information from what we had just 2 months ago.
Yeah.
Well, I will tell you, Amanda, I pride myself in going in depth about things and teaching you guys the pathophysiology because it's so important. It's how can I expect you to understand the drugs and what they do and how they work if you don't know how the human body is working? So I really try to give more information than is even necessary. I hope that's okay with you because it's just kind of what I do.
No, it's good teaching.
Huh?
I said no, it's good teaching.
Okay, good. Sometimes I can go on tangents and just talk and talk and talk. So hopefully it's helpful. I'm sorry if I make you feel overwhelmed with all of my words, but I swear it's because I want to help you. Okay. Can I
Listen,
say
as
something
long
real
as you break it down good enough and give as most information as you can so we can understand it and pass these exams in this class, I will be one happy person.
Amen. Amen.
Yep.
That's why it's grinding my gears that this
I
video is
agree
taking
with you.
process because I'm like, I want to get it out to you because I know it's a lot all at one time. To sit here for hours and hours and hours. Like I remember the days of sitting in class for 4 or 5 hours, and it's like, it's so hard it's impossible to retain all of that information from one day, for so many hours. And then to have 2 lecture days in a row also is difficult. Because you're still processing what happened yesterday, and now all of a sudden you have to process what's going on today. So, but what is nice is you have the rest of the week to go over stuff. So, yeah.
So yesterday when you were pointing at the screen in the room,
Yeah.
the people in here can't see what you're pointing at.
I know. Every time I move, I try to like move my camera with me. I don't know. Maybe if I keep my laptop over here so you can see this screen. I don't know. Would that be helpful? Do you like the lights on? I think the lights on. Okay, so would that be helpful?
I
If
mean,
I
it
put
can't hurt.
Well, can you still hear me well? Because I'm talking to you through my laptop.
Oh yeah, we can absolutely hear you.
Okay. Okay. Are we ready? She's still grabbing stuff. Yeah. We can get it later. Tell her don't worry about it. And then just close the door when you come back in.
Can I ask a quick question?
Sure.
Cause okay, so I know we have lecture next Monday, and then our exam is on Tuesday, but I know week 1 we have like 9 chapters altogether to cover. So like, are we gonna finish the rest today, or are we gonna finish it on Monday, and it's all gonna be on the exam Tuesday? Does that make sense?
Yeah. Honestly, a great question. I don't know. I don't know what we're gonna get through today. I'm hoping to get through everything today, but I mean, it just depends on how much time we take on each subject. And how fast we get through it, because we have 44, 45, 46, 47, 48, 49. We have 6 chapters to get through today. And we're already a half hour behind, which is my fault because I was printing things. So, okay, ready? All right. Sorry about the mess. At least we have them. Okay. All right. So, chapter 44, we're talking about drugs for heart failure. So heart failure is a condition in which the heart fails to effectively pump throughout the body due to structural and or functional irregularities in the heart. There is low cardiac output. So there's 4 stages to heart failure. Stage A is a high risk for heart failure, but there's no structural heart disease. So damage hasn't actually happened yet. And then stage B is that there are structural heart disease, but no signs or symptoms of heart failure. Stage C, structural heart disease with prior or current symptoms of heart failure, and then refractory heart failure requiring specialized interventions. So as we go from A to D, the symptoms are becoming more severe, and the disease to the heart is becoming more severe. So functional classifications, class 1, there's no limitation of physical activity. Class 2, there's slight limitation. Class 3, there's a lot of limitation. And then class 4, unable to perform any physical activity without symptoms or symptoms at rest. Usually involves dysfunction of cardiac muscle. So this is your patient that from one standpoint can walk up the stairs, and then as their disease progresses, they are short of breath, have significant edema, and are extremely symptomatic just sitting in front of you. Okay. So this slide is just talking about those muscle fibers again. And the calcium ions going in and out, we're not getting into that. So some common disorders that lead to heart failure would be coronary artery, hypertension, and valvular heart disease. Anything that is going to weaken the heart muscle, okay? Compensatory mechanisms. Our body is full of the ability of compensation. Because remember, we are always constantly fighting to stay in a homeostatic state. So the only way we can do that is with our body having natural compensatory mechanisms. So if you have decreased cardiac output, it stimulates the sympathetic nervous system. It stimulates positive inotropic effects and release of renin. So it's going to stimulate the heart to work harder to increase your cardiac output. Okay. Over time, compensation mechanisms increase the heart's workload. The muscle stretches and thickens, which is where we get ventricular hypertrophy. Chambers are not able to effectively pump blood, which leads to decreased cardiac output. And then this leads to increased heart failure. So the harder that the ventricles have to work to get the blood out, whether it's the right side getting it to the lungs or the left side getting it to the periphery, to the body, will eventually lead to hypertrophy, which will eventually lead to heart failure. These are just talking about the mechanisms for heart failure. So if you have decreased myocardial function or failure, it is going to lead to decreased cardiac output, okay? So those things are going to stimulate the baroreceptors stimulation, which is going to increase your blood pressure because the baroreceptors are within your artery walls. And that causes vasoconstriction, which is going to increase your blood pressure, which is going to try to increase your cardiac output. Okay. So it causes a sympathetic activation, which increases your blood pressure, increases your pulse, respirations, and increases your cardiac output. So when we have decreased output, we have decreased blood flow to the kidneys. This activates our renin, angiotensin, aldosterone system, right? Because our juxtaglomerular cells are saying, hey, there's not enough pressure here. There's not enough cardiac output here. We need to do something about it. So then our blood pressure goes up, okay? So this leads to increased blood pressure, increased cardiac output. And both of these are going to increase the aldosterone. So when we increase our aldosterone, what does that cause your kidneys to do?
Retain water and sodium.
Yes. Is my volume up? Yes. Retain water and sodium. So when we have an increase in aldosterone, we have an increase in sodium retention, an increase in potassium excretion, because when sodium goes up, potassium goes down, okay? And then we have an increase in water retention, which causes an increase in blood volume. So do you see all of this started because of a decreased cardiac output? This is what's called your negative feedback system. okay? It works in every single aspect of the human body. It is the only way that we are constantly reaching homeostasis by a negative feedback loop. Something is triggering something, which triggers something, which triggers something. It's a constant domino effect, constant cycle. Does that make sense? Okay. So we have signs and symptoms of heart failure. I know this is really small, but I hope you have, I mean, I know my people here have their slides printed, and you guys at home, I know you can zoom in on your screens. I do need you to know the difference between right-sided heart failure and left-sided heart failure and know the symptoms and why. So if I have right-sided heart failure and I have JVD, first of all, what is JVD?
Jugular vein distension.
Jugular venous distension, okay. If I have jugular venous distension from right heart failure, why? If I have
Edema?
left-sided heart failure,
have-
where is the
You have fluid overload?
yes? So if you have left-sided heart failure, left lungs, LL, left lungs, left-sided heart failure leads to pulmonary congestion, okay? Right-sided heart failure leads to peripheral edema, okay? When heart failure gets severe enough and those compensatory mechanisms no longer are working, that congestion, that edema is going to be everywhere. So it doesn't really at that point, is it right? Is it left? I don't know, because we have pulmonary congestion, we have peripheral edema, we have everything everywhere. We have every symptom. Because when it gets severe enough, the one side failing is going to cause the other side to fail also. Okay. So with right-sided, we have, where's my paper? Splenomegaly, hepatomegaly, decreased renal perfusion when you're standing, increased renal perfusion when you're laying, and a symptom of that can be nocturia. What is nocturia?
Frequent peeing at
Excessive
night.
urination at night.
Urination at night, yes. So because your kidneys are having increased perfusion while you're laying down and sleeping, then all of a sudden, I gotta pee, I gotta pee, I gotta pee. But when you're upright all day, your kidneys aren't perfusing very well, so you have decreased urinary output. Okay. We also have pitting edema and weakness and fatigue. So then on the left side, we have anxiety, tachypnea, dyspnea, orthopnea, hemoptysis. What is hemoptysis? Coughing up blood, yes. Rails, what are rails?
Crackles.
They're really intense lung sounds. Okay. Cardiomegaly, which is megaly, is an increase in size. So when we're talking about hepatomegaly, we're talking about a enlarged liver. Splenomegaly, we're talking about an enlarged spleen. Cardiomegaly, an enlarged heart. Increased heart rate, GI upset, nausea, abdominal pain, decreased peripheral pulses, and hypoxia. So it's going to be important that you can differentiate what symptoms belong on which side. Okay.
I'm sorry, quick question.
Yeah.
You said left was lungs, but what was right?
Right is the periphery. So you'll see a lot of peripheral edema with right-sided heart failure.
Thank you.
Okay, so bless you. The treatment algorithm, this is so slow. So this is just talking about treatment with your glomerular filtration rate and what type of diuretics. This is a little too sciencey for us at this point, so I'm not going to get too far into it, because we just don't need to. This is talking about, this is the negative feedback system that we were just talking about, but now it's adding in where these drugs work, okay? So if you were to take inotropic drugs, they work at the myocardial function. So if you take nitrates or vasodilators, those work at the baroreceptors. So it's telling you where it's working within the renin, angiotensin, aldosterone system. Okay, because each of these drugs work in a different place in that system. Okay, so the reason your vasodilators are working on the baroreceptors is because your baroreceptors are within your arteries, which cause vasoconstriction. So if they inhibit vasoconstriction, they're going to cause vasodilation. Okay, so if your diuretics are working all the way down here within the kidney, where we're talking about sodium retention, potassium retention, and increased water retention, your loop diuretics are going to work here so that we can release that fluid that's being held onto, right? Our ACE inhibitors and ARDs are working here to block angiotensin 2, which is right here, which is activated by the kidneys and then tells the liver, and then angiotensin 1 goes to angiotensin 2 in the lungs, right? Then we go to the arteries where the baroreceptors are. Then we go to the adrenal cortex, which is right on top of the kidneys, which causes a release of aldosterone, which then causes all of this: increased sodium retention, increased water retention, right? So it starts at the kidneys and then goes all the way back to the kidneys, okay? Okay, so this is a very important drug that I need you to know things about. I need you to practically know everything about this drug. This drug is called digoxin. It is used to treat heart failure symptoms. You're going to see this again because it's also an antiarrhythmic. The action of this is that it increases intracellular calcium, allows more calcium to enter the myocardial cell during depolarization. What is depolarization? Contraction. Repolarization, relax. Repolarization, relax. Depolarization is contraction. Okay. Increased force of myocardial contraction, increased cardiac output. So if it's increasing the calcium, we need calcium for strong cardiac contraction, right? So if it's increasing the calcium, it's forcing more and stronger myocardial contractions. Okay, if you have stronger contractions, you have increased cardiac output. If you have increased cardiac output, you have greater renal perfusion. Okay, digoxin, like I said, is also an antiarrhythmic, which slows the heart rate. Okay, so this is going to control your rate also. You have decreased conduction velocity. So that means that it is also working on the electrical activity of the heart. Arrhythmias occur from erratic electrical activity. So if it's decreasing the conduction velocity, that means that if a person with AFib is taking digoxin, it can slow the conduction from the SA node to the AV node to maybe slow down and stop fibrillating. So we can then correct the AFib. That makes sense? Okay. Overall effect is to increase the cardiac output. That's the goal for all of this, is to increase cardiac. So your indications are going to be treatment of heart failure, flutter, AFib, paroxysmal atrial tachycardia. It has a rapid onset. It is absorbed rapidly and widely distributed throughout the body, and it is excreted unchanged in the urine. Do you see the difference here with all the drugs we talked about yesterday? What is the difference?
That one's unchanged.
Right, but we're also not talking about hepatotoxicity. What's that? Oh, those are mine. Yeah, thank you.
Paying delivery for you.
Thanks, ma'am.
It's not help out.
You.
Okay.
So a lot of the drugs that we talked about yesterday were not only nephrotoxic, they were hepatotoxic, but this is only nephrotoxic. It's not metabolized in the liver. Okay. So contraindications include obviously allergies. I'm gonna get so sick of saying that. VTAC or VFib, because this drug does not treat ventricular arrhythmias. It treats atrial arrhythmias. Okay. You do not want to take this drug for a heart block or sick sinus syndrome. Idiopathic hypertrophic subaortic stenosis, with a lot of words. So stenosis, osis is a condition. Stenosis, this would be a condition of hardening. Okay. Subaortic, so sub meaning below, so below the aorta. Hypertrophic, this is an increase in size. And idiopathic, meaning we don't know why. So this is, I don't know why, but you have an enlarged below the aorta hardening. Okay. Remember our med term? It really helps when you don't know what something is to be able to break those words down. Okay. An acute MI, renal insufficiency. We just said it was nephrotoxic, right? So you don't want to take this if you have renal insufficiency already. Electrolyte abnormalities. Why? I said this yesterday. I don't expect you to remember everything I say, even though I want you to. But digoxin has a really strong link to potassium. Okay. So if you are hypokalemic, you are at a higher risk for digoxin toxicity. Okay. And you want to use caution in pregnancy and lactation. So on page 777, under contraindications, it talks about the electrolyte levels. It says, and electrolyte abnormalities, increased calcium, decreased potassium, and decreased magnesium, which could alter the action potential and change the effects of the drug. Your therapeutic dose for digoxin, your therapeutic serum levels for digoxin is 0.5 to 2. I expect you to know that. That is the therapeutic range for digoxin.
Can you repeat that for me, please?
0.5 to 2. Everything you need to know about digoxin starts on page 775 all the way to 779. So it causes an increase in calcium, a decrease in potassium, and a decrease in magnesium. So if your patient is hypokalemic, they are at a higher risk for DIG toxicity. I need you to know that. So adverse effects most frequently seen is a headache, weakness, drowsiness, and vision changes. What is your zebra here?
Vision changes.
Vision changes. Does anybody have their book open to page 777?
Yeah.
And what does it say about adverse effects and vision changes for digoxin?
The yellow halo.
I'm so happy you guys have your books open. That just made me so proud. Okay, yes. So this is a yellow halo around objects. This is the hallmark sign of digoxin toxicity. Okay. Your patient is like, wow, these lights are looking funny today. And they have green and yellow halos around the lights. Okay, that is not normal. So other symptoms of DIG toxicity would be anorexia. And just to be clear, when we are talking about anorexia versus anorexia nervosa, the second is an eating disorder, which comes from the human that wants to not eat. Okay. And then it becomes a lot deeper than that. When we're talking about just anorexia, we're talking about a person that can't eat, that feels like they can't eat. They don't have an appetite. The drug has made them feel like they have no appetite. They have no desire for food. Okay. So these are two completely different things. And I don't want you to think that it's the same. Okay. I don't want anybody to think that I'm like making light of anorexia nervosa because EDs can be very triggering. I'm not. I just want to make sure you know that there's a difference. And it's not the time for us to actually go into the pathophysiology of anorexia nervosa. So just in case you feel some type of way, please don't. Okay? All right. Moving on. Drug-drug interactions. You do not want to use this drug with verapamil. What is verapamil? What classification of drug is verapamil? I needed you to know this yesterday. We talked about it.
A calcium channel blocker.
A calcium channel blocker. It is a special calcium channel blocker, just like cardizem or diltiazem, which is the same drug, just a different name. Okay, those are the separate calcium channel blockers that are more for arrhythmias than they are for hypertension. Okay. Amiodarone, we'll get to amiodarone eventually. Erythromycin, tetracycline, cyclosporines, those are all antibiotics. So we do have drug-drug interactions that hopefully the pharmacist or your PCP or somebody says, oh, you shouldn't be taking digoxin because you take XYZ. Okay. Potassium losing diuretics. So not sparing. So what are those?
It's Lasix.
Lasix, furosemide, which is Lasix. What is another loop diuretic that is also very common in the acute care setting? That is also a loop diuretic. Starts with a B. Bumex. Bumex is the brand name. The generic name is bumetadine. We'll get there when we talk about diuretics. I just wanted to see if you knew. You want to be careful with thyroid hormones. Metoclopramide, which is Reglan. We're going to talk about that in a couple weeks. And then just to put this out there, never in a million years are you ever going to get instructions to take drugs with antacids. If you ever see a question and one of the answers is to take with an antacid, it is wrong. Okay? I promise you that.
That was awkward.
I bet it was. I'll prep you. Okay. All right, so this is just looking a little bit closer at digoxin, treatment of heart failure, AFib, also A-flutter. Our zebra here is visual disturbances. It's important to know that our therapeutic level is 0.5 to 2. And it's important to know the signs and symptoms of dig toxicity. Also, what is extremely important to know is the antidote for digoxin. Okay, the antidote for digoxin is called digoxin immune fab, 3 words. Digoxin immune fab, like FAB. The brand name is called DigiFab, DIGFAB, 1 word. Digoxin is a classic NCLEX drug. Because there are so many zebras, there is a specific antidote, there are specific signs and symptoms, and specific electrolyte disturbances that go along with it. So don't just learn it for me, but learn it in general so that when it comes up, you recognize it and you can answer it correctly. So, question, the first goal of treatment for heart failure is to make the heart beat harder and faster.
No.
False.
That is false. The goal of treatment is to decrease the work on the heart because the heart is already working really hard. We don't need it to work harder. We're not going to spend a lot of time on this drug. This is milrinone. It is the only drug available in this class, phosphodiesterase inhibitors. It is only for short-term use of heart failure that has not responded to digoxin or diuretics. And it's really limited. It's not given often. Okay. So like I said, I'm not going to get into it. The only thing that is really important about this is that it's available only for IV use. You don't want to use it if you have any ventricular arrhythmias, an acute MI, severe aortic or pulmonic disease. And like I said, it is only available for IV use. You can have really bad burning at the IV site. And for adverse effects, they're pretty severe. The most frequently seen, which means it happens often, arrhythmias. I don't want to give a drug that causes arrhythmias very often. That makes me nervous, which is why it's not given often. So if you are giving this drug, there are some nursing considerations that you would want to know your history of your patient and make sure you assess that patient. By the way, we are not giving drugs to patients that we have not assessed ourselves, correct? If you are going to put your nursing license on the line to give a drug to a patient that you have not assessed, you need to sit down and probably think about your actions because that's how you lose your license, okay? That's how you hurt a patient, by making sure that you're not doing something safe. So this is really important. Drug-drug interactions with furosemide. Furosemide is one of the most commonly used medications in acute care because it is the easiest and most what's the word? Effective loop diuretic. So it's used often, very, very often. So if your patient is taking this drug, they can't. So it would be important to know that drug-to-drug interaction. Good. This is also a drug that you will really never see in practice unless you work in a very specific cardiac situation. The indication is to reduce the risk of hospitalization for worsening heart failure. Yeah. I don't need you really to know anything about this. You do not want to give this drug if your heart rate is less than 60, which is most common for almost every single cardiac drug, is that you should not give it unless told if you have a heart rate less than 60. This is a very common medication. This drug, Entresto, it's a combination of valsartan and sacubitril. I wonder if I said that right. Sacubitril. So this blocks the breakdown of natriuretic peptides, which inhibits the effects on the renin-angiotensin-aldosterone system. So it leads to decreased cardiac workload. It lowers the vascular volume, which means it lowers the volume that you have in your body. So it probably increases urination also. Lowers blood pressure and improved heart failure symptoms. Entresto is a very common medication for patients to take at home. So this reduces the risk of cardiovascular death and hospitalization in adults with chronic heart failure. The treatment of symptomatic heart failure with systemic left ventricular systolic dysfunction in pediatric patients over 1 year of age. So it's very specific when it comes to peds. Okay. After oral administration, it breaks apart those two drugs. The sacubitril is metabolized differently than the valsartan, and it's eliminated in the urine and feces, which makes us think that it can be nephrotoxic. So, because valsartan is a sartan, and it is what kind of drug?
Arbs. Arbs.
Arbs. If you have a history of angioedema related to the exposure from an ACE or an ARB, you cannot take this drug. Okay. If you have already had a history of angioedema, you should never take an ACE or an ARB ever again. Okay. Your common effects would be hypotension, hyperkalemia, because remember, ACE inhibitors and ARBs increase your potassium retention, puts us at a higher risk for hyperkalemia. Okay. Cough, dizziness, renal impairment, monitor patients for signs of low blood pressure and angioedema. Drug-to-drug interactions would include other ACE inhibitors, potassium-sparing diuretics, lithium, and other nephrotoxic medications, because we're already at risk for hyperkalemia. Why would we want to spare more potassium? The nurse is caring for a patient who has presented to the ED with signs and symptoms of an acute MI. While making an initial assessment of this patient, the nurse notes that the patient has had adverse reactions to digoxin and a history of heart failure. The physician writes admission orders. Which of the following drugs would be of concern?
B.
B. Milrinone. Because you want to be cautious with patients that could have severe aortic or pulmonary valvular disease, acute MI, increased renal perfusion, ventricular arrhythmias, which could be exacerbated by ventricular arrest. Any questions on chapter 44? All right, let's take 10 minutes. And we'll start with chapter 45.
I think it's the rest of the PowerPoint. Okay. I don't know what these 3 random pages are. Got that out there. There. Yeah. Eight. Wait. Well, never mind. Don't know what are the papers. 58. 58. 59? Yeah. Yeah. Thank you. And there's 60. Thank you. Yeah, there's so many. 60. 59. 8. Still fairly promising. That's how much. Just go somewhere. Kimmy just said, "How's class going?" And I'm like, "It's giving me anxiety looking at the point." She just kind of like, "Why did she do that?" Like, I don't know. I feel like it's not the right way looking at it, but it's inevitable. I think. So just I have to say, is there anything after? I didn't look at week 4. Also, between these changes, I don't have to say it older with things, so I'm not sure. So I say the follow up. Now that she printed them all out. I'm missing 17. Is there 70? Well, how am I missing 17? It's literally, I think, the only one I'm missing. Did you print 17?
Maybe.
Because I seriously think that's the only one I don't see. As I'm sitting here looking at it. So I thought maybe it was just me. I didn't see 17 in the last stack. I have 16 and I have 18.
I shall continue.
Although somebody else has it. I just don't see it. Honestly.
I know there's so many.
everywhere. I don't think
Probably how you don't want to get it right.
No, I have to go to work again today right after, I think.
I'll go to Office Max. Crazy expensive thing.
I think 17
Make a reminder.
the only one I'm missing, I think. Don't quote me on it.
Yeah, there's the cooler so the bid.
These are 60.
I've been doing nothing. I worked on homework. Met everybody yesterday. I thought about it. Anything good in the cooler, but then I just. Oh, I'll go on.
Oh, the other day we were at my grandma's to do her trick or treating. And I was like, oh, I'm gonna go see if grandma has any cold water. She goes, oh, go in the back of my van, there's a cooler. So I go back there, I pull out baby water. I said, you did not just send me out here to get a baby water.
There's also Gatorade. There's a Java Monster back there.
Who needs 17? How many?
I do.
Me.
Maybe 4.
No, I have 6.
I don't see 17. I don't actually have it, honestly.
Java Monster.
Okay, so they are being printed all the way down the hall by the faculty. Oh, well, I just printed more.
Words a lot of us everywhere. Yeah, that is fine. Yeah, right.
Yes, I have very big shred boxes. So whatever papers we don't need, put them in a pile and I will recycle them.
I don't think all the yeah. Good. I get it.
Cause I just brought my niece's birthday.
Yeah, you got a whole stack sit on your desk at home. Cause I printed, I don't think my binder's big enough. I think if I go, I just count. Let's go get a bigger binder.
Yeah.
Yeah, here's my 2 inches.
Oh, yeah, I'm gonna go get a bigger binder. I'm gonna need a bigger book bag. My stuff really.
I never got a clinical bridge, like account and worksheets for clinicals.
Wait, what?
I never got an email. I got a email from Missy that says I need to complete my clinical bridge EXP account and some
Oh,
work.
yes. That's called bridges. That's how you get access to your hospital rotation. You have to get in there and make sure you upload all of your health requirements, or you will not be going to clinical.
Okay, so I never got anything to like account.
Did you see? She
You never
sent
got
it
what?
on the 18th.
I didn't.
Yeah, please
Well,
get this fixed today,
I don't
or
have
you will
any
not be allowed
emails. It just says I need to complete it, but I don't even know what it is.
Okay, so can you please reach out to Missy and have her help you with that? Because if you don't go to clinical, you fail the course. And I really don't want
Okay.
that to happen. So please send an email to Missy right this very moment. Please, please, please. And
Okay.
tell her you need more information or something to complete your Bridges
For the
account
health
because
requirements, it's Roby. I can send her thing in the
correct.
chat if you want.
Correct. So Kara will be able to send you your background check, your flu shot, your TB, all the things that she has on file for you. She will be able to send you. And also, if you sent all of that stuff to her in an email, you also have that in your outbox. So look in your
Okay.
outbox. If you send it to Kara Roby, it will be there. Okay. But you
Okay.
need to get a hold of Missy as soon as possible and get that done for you to be able to go to clinical.
Okay. Thank you.
Thank you. Is anybody else having an issue with Bridges or haven't done their health requirements for clinical? If so, you better get it fixed today. All right. Which chapter are you looking for? 15. 15. I think 15. All right. 5. Oh, that looks better. Okay, so in this chapter, we are talking about antiarrhythmics. And in order to understand antiarrhythmics, you need to understand the cardiac conduction system, which we talked about yesterday. So your cardiac conduction system starts at the SA node, which is also known as the pacemaker of the heart, then goes to the AV node. The AV node slows the conduction so that the atria can contract and the ventricles aren't contracting at the same time as the atria. Okay, so there's a slowing of conduction at the AV node. Then we go into the bundle of His, which then leads to the Purkinje fibers, which the Purkinje fibers wrap around the right and left ventricle. Okay, and those Purkinje fibers are what cause ventricular contraction. So the red ones cause atrial contraction, the blue ones cause ventricular contraction. It is important that you know the steps of the cardiac conduction system. So this talks about the action potential of the cardiac muscle. So phase 0 occurs when the cell reaches a point of stimulation. Phase 1 is the short period when fast sodium ion channels close and there is a decreased permeability of sodium. This is very sciencey. I am not going to ask you questions on the phases of the action potential of cardiac muscle cells. What matters to me is that you understand that potassium is important in your cardiac cell function. Sodium is important in your cardiac cell function. Calcium is so important in your cardiac cell function. If you have an electrolyte disturbance in those, going to have arrhythmias. Most important part of it. So, phase 2, which becomes less permeable to potassium, and calcium slowly enters the cell. When we have an influx of calcium, we know that it helps with cardiac contraction, right? Because of calcium channel blockers. Okay. And phase 4 occurs when the cell comes to resting membrane potential. So this is literally just saying it starts here, rapid influx of ions cause depolarization, and then we have to go to a phase of rest. So after every contraction, there must be repolarization of rest in order to have an adequate cardiac output. Okay. So arrhythmias occur when there are changes to the automaticity or conductivity of the heart cells. Factors include electrolyte disturbances, which I've been saying for days now, 2 days. Decreased oxygen delivery to the cells. So if there is hypoxia that is occurring within the coronary arteries, the myocardial tissue is not being oxygenated, an arrhythmia can occur. Structural damage that changes the conduction pathway. So if something has happened, there has become ischemia in the SA node. And the SA node is now not firing properly because that tissue has died. Okay? That will cause the SA node to not fire correctly. If there is ischemia that occurs in the Purkinje fibers, then you may not have ventricular contraction the way that you need to contract for cardiac output. Does that make sense? Acidosis or waste production accumulation. So acidosis like diabetes, when your body is in a very acidic state, it can cause arrhythmias. Drugs that alter the action potential or cardiac conduction. So antiarrhythmics or any other drug that says that it can alter your cardiac conduction. Okay. Causes of cardiac arrhythmias, changes in rate. So tachycardia, we all know what tachycardia is, right? So it's a rate over 100. Bradycardia is slower, so it's a rate lower than 60. Stimulation from ectopic focus. We're not going to get into PACs yet. That's we're going to do that in complex care. PVCs though, PVCs you're going to see significantly in acute care. You could have a PVC sitting right here. It's actually, PVCs are the most common arrhythmias. You ever feel like you're just sitting there or standing there and you feel like you're this weird feeling in your chest where it just kind of like drops for a second? And you're like, oh my God, what was that? That's a PVC. That feeling, that is an arrhythmia that just occurred. But it happens all the time. PVCs are not dangerous unless they happen in congruency with more PVCs. When you have a run of more than 3 PVCs in a row, that's what we call VTAC. Now, the problem with VTAC is if it's sustained or unsustained. So you can have a run of VTAC and be okay. And you call your doctor, or you're the nurse and you call the cardiologist and say, hey, my patient just had 7 beats of VTAC. And they're like, okay, I'll come see them later, Or your patient has sustained VTAC. We ask what question? Do they have a pulse? Because pulseless VTAC and a patient with a pulse with VTAC are 2 very different things. Okay. A-flutter, atrial fibrillation, and ventricular fibrillation. Ventricular fibrillation equals dead. AFib, defib. Okay. This is when you bust out your defibrillator and you go clear. Okay. You always want to shock defib or VFib. You do not shock a system. alterations in conduction throughout the muscle. So have you seen AFib? If AFib was staring you right in the face, would you know what it is? Yes. She says yes. Why? AFib. Oh, bless you. Were you on an anticoagulant? Yes, I know. For the rest of your life? Yes. Yeah. We're going to talk about it. Okay. So if you look on page 795, it gives you many examples of PVCs. And it looks like a regular heartbeat, and then all of a sudden it goes whoop, whoop, whoop. So if you go whoop, 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 that's VTech. Okay. But random PVCs are normally not really an issue until they become an issue. Okay. True or false? One factor in the development of cardiac arrhythmias is a decrease in oxygen delivered to the cells. True. Okay, so there are 4 classes of antiarrhythmic drugs. I do want you, does everybody have their books open to page 794 or 795? Okay. So, have we all seen an EKG strip? Okay. So the first picture at the top of 794 is normal sinus rhythm. Okay. The second one down farther, picture A, is PACs, premature atrial contractions, which I told you we're not really going to get into right now. They're also not very common. Picture B is AFib. So there are 2 characteristics of AFib. The first characteristic is that there is no P wave. The P wave is the little tiny wave right before the big QRS. Okay. So the first characteristic of AFib or A flutter is there are no distinguishable P waves. The second characteristic of AFib is that it is irregular. So you see the, when we're talking about the Q, right? Here's the Q, and then here's the R, the tip of the R, and then the S comes down, right? So we're looking at the R to R interval. So the space between the spikes. If you have a normal regular heart rate, those R's, those QRS's, the tips of the R's, are going to be regular, in a regular pattern. They're going to have the same amount of boxes between each of them, okay? When you have an irregular rhythm, you have different R, okay? So if you have 1, 2, like it's kind of to the 4th and the and in between is AFib. Everything on page 795 are examples of PVCs and what they can look like. And then on page 796 is VFib, ventricular fibrillation, which equals what? Dead. VFib equals dead. Okay. So there are 1, 2, 3, 4, 5 classifications of antiarrhythmic agents. We already discussed the first one, which is your digoxin. Class 1 is sodium channel blockers. Class 2 act on autonomic receptors. So the auto system, not the sympathetic nervous system, the autonomic nervous system. Class 3 acts on potassium channels, and class 4 moderates calcium channels. You have some subclasses. So Class 1 antiarrhythmics, they stabilize cell membranes by binding to sodium channels, depressing phase 0 of the action potential, and changing the duration of that action. So class 1, the sodium channel, first, stupid. Yes, sodium channel blockers are preferable in conditions for ventricular arrhythmias. Okay, so this is the treatment of potentially life-threatening ventricular arrhythmias. It is widely, I keep wanting to say wildly, because that's what my brain reads, wildly. Widely distributed after injection or rapid absorption through the GI tract. It undergoes extensive hepatic metabolism and is excreted in the urine, so it's going to be both nephrotoxic and hepatotoxic. You do not want to use an antiarrhythmic for a patient that is already bradycardic or in a heart block, has heart failure, hypotension, or any form of shock, electrolyte disturbances because it works with these sodium channels. Okay. And you want to use caution for renal or hepatic dysfunction and no pregnancy. So your adverse effects are going to include CNS effects. So whenever, like I said yesterday, when we talk about CNS effects, we're talking about hypoxia to the brain. We're talking about weakness, dizziness, fatigue, lightheadedness, syncope, because that's what happens when our brains aren't getting enough oxygen. GI effects are always going to include some form of nausea, vomiting, diarrhea. When we talk about cardiovascular effects, it includes pro-arrhythmic effects that lead to the development of arrhythmias, including heart blocks, hypotension, cardiac arrest. So these are really high-risk drugs, okay? They have a lot of serious side effects. This is all on page 799. Respiratory depression progressing to respiratory arrest can also occur. Other adverse effects include rash, hypersensitivity, loss of hair, potential bone marrow depression, so decreased immune system. And then procainamide has a boxed warning regarding risk of development of positive anti-nuclear antibody test with or without symptoms of systemic lupus. So this means that you can develop lupus-like symptoms and even test positive for lupus just because of this drug. And that's on page 799.
Sorry, is that for taking it or for handling
Taking
it? Okay.
So these class 1 drugs, your most common are going to be lidocaine. And I'm not talking about lidocaine from the dentist. I'm talking about IV lidocaine. Okay. Another common one is going to be I guess they're not really. The only one you're going to really recognize is the lidocaine. But they are all listed on page 797 under class 1 antiarrhythmias. So it's important to know that these drugs have drug-to-drug interactions. So quinidine should not be taken with digoxin. That's important to know. You should not take these drugs if you take Coumadin or warfarin. You should not drink grapefruit juice with these drugs. You should not drink milk or orange juice when you take this drug. See how it says citrus fruits, vegetables, and acids, milk products? So if you were to have a question that says your patient was administered a class 1 I take this in the morning with my whole milk. You need to be able to identify, you need to provide more education for your patient, right? Because your patient is taking this drug with something that they should not be taking it with. Okay? So this just takes a closer look on lidocaine. This is for the management of acute ventricular arrhythmias during cardiac surgery or MI. Treatment of refractory ventricular arrhythmias. You can have, like this tells you, your CNS effects, dizziness, lightheadedness, fatigue. Then you can have your cardiovascular effects, arrhythmias, cardiac arrest. Then you have your GI, nausea, vomiting. Anaphylaxis is always an issue with everything that we could possibly ever consume. Hypotension and vasodilation. Class 2 antiarrhythmics. So many are beta adrenergic blockers that block beta receptors. Do you know anything about beta? If I were to say to you beta 1, beta 2, do you know what that means?
Beta 1 is the heart and beta 2 is the lungs.
Yes, ma'am. Yes, ma'am. So beta 1, you have one heart. Beta 2, you have 2 lungs. It's an easy way to remember which one goes where. So if you have one that is more specific towards beta 1, it works more on the heart tissue. If you have one that's more specific to beta 2, it works more on the lungs. If you have something that's called a non-specific beta blocker, which means it works on both, which we're going to get to one of them, like metoprolol or albuterol, okay? It can cause issues with the heart and lungs, okay? Because it can affect both beta receptors. So, I believe I have a star. I believe there's a question somewhere where it asks you where beta receptors are found. Maybe it's a different question I'm thinking about. But I will know if I find it. Okay. So, again, many competitively block beta receptor sites in the heart and kidneys. I know I said heart and lungs because beta 1, 1 heart, beta 2, 2 lungs, but you also have beta receptors in your kidneys. So the result is a decreased heart rate, cardiac excitability, cardiac output, slowing of conduction through the AV node, and decreased renin. So if it's slowing the conduction through the atria, are we treating atrial arrhythmias or ventricular arrhythmias?
Can you repeat that?
If we are slowing conduction through the AV node, are we slowing atrial conduction or atrial arrhythmias
Atrial.
or ventricular arrhythmias? Atrial, yes. So the indication is the treatment of rapid AFib, A flutter, paroxysmal SVTs, supraventricular tachycardia, hypertension, angina, PVCs, and VTAC. So these drugs are absorbed from the GI tract. They undergo hepatic metabolism and excreted in the urine. So they are going to be hepatotoxic and nephrotoxic. Your contraindications are sinus bradycardia and a atrioventricular block, which is a type of heart block, cardiogenic shock or respiratory depression. Contraindicated with hold on. I like to make sure I say it right because I don't like to backtrack and be like, oh no, never mind. I want you to hear this. I want you to hear it right the first time. So your class 2 antiarrhythmics include adenosine, digoxin, esmolol, and propranolol. Okay. So for contraindications, caution should be used in patients with diabetes and thyroid dysfunction, which could be altered by the blockade of the beta receptors. This is very important, by the way, on page 801. Patients with asthma or COPD who may have respiratory distress due to reduced ability to dilate the bronchi. That is very, very important because what did we say? Beta 1, 1 heart, beta 2, 2 lungs. If it's working on the heart and the lungs, it can cause asthmatics or patients with COPD to bronchoconstrict, which is going to decrease the size of their airway and cause respiratory distress.
Sorry, what page was that on?
801.
Thank you.
Adenosine is part of this classification. Adenosine is a very special drug. Has anybody ever heard of adenosine? Okay.
Yes.
So adenosine is specifically used to treat SVT, which is supraventricular tachycardia. Okay. And it is a drug that has to be given rapidly, like literally as fast as humanly possible, because it has a very, very short half-life. Okay. And what adenosine does is actually very scary. If your patient is an SVT and you give adenosine very, very quickly, what is going to happen is your patient is going to go asystole in front of you. Okay. And after a few seconds of them being in asystole, which means there is no electrical activity occurring in their heart, the goal is for them to spontaneously return to normal sinus rhythm. Okay. You can give adenosine for a total of 3 times. The first time you start at 6 milligrams. 6 milligrams doesn't work, you can go to 12 milligrams. 12 milligrams doesn't work, you can do 12 milligrams again. After that, you cannot use any more adenosine. And you would have to use some other form of breaking them out of SVT. Okay. So this is saying that since adenosine slows conduction through the AV node, and decreases the automaticity in the AV node, it is contraindicated in patients with second or third degree AV blocks. So that's what this means, is you should not use adenosine for patients that have a second degree or third degree heart block. So you want to use caution in patients, again, like I just said, with diabetes or thyroid dysfunction. Specifically, I would put a star next to asthma and COPD. Drug-to-drug interactions, verapamil or diltiazem, which is what? Are special calcium channel blockers, which can be used for arrhythmias. Okay. Some anti-diabetic medications, and theophylline and caffeine, which we'll get to those. So this is looking at propranolol. Propranolol is a beta blocker. All your beta blockers end in olol. That's how we recognize them. So it has adverse effects of bradycardia, heart failure, cardiac arrhythmias, heart blocks. So you wouldn't want to give this to a patient that is already bradycardic, or already has heart failure, or already has cardiac AV arrhythmias like a second or third degree heart block. So then we move on to class 3 antibiotics. This is going to be your amiodarone or sodal. Those are two different drugs, not the same. So this works by blocking the potassium channels, slowing the outward movement of potassium during phase 3 of the action potential, and prolonging it. This is for the treatment of life-threatening ventricular arrhythmias and the maintenance of sinus rhythm in patients with symptomatic AFib or A-flutter. So this can be used for both atrial and ventricular arrhythmias. So this is well absorbed after oral administration, and immediately available after IV administration. With amiodarone, usually if you have a patient that's an AFib, they're trying to break out of AFib, you can have an order to bolus amiodarone, which means you give a large dose, and then they are on a drip, so an IV drip of that amiodarone for an extended period of time. This is also the same situation with cardizem. It happens very often with cardizem. Contraindications, there are none when used for life-threatening arrhythmias, because guess what? You can't get any more dead. Okay. Ooh, that's a word. Ibutilide, and dofetilide, you do not want to give with atrioventricular blocks. So second degree blocks or third degree blocks. I don't even know what that medication. Never seen it, never heard of it. But you don't want to give it with permanent AFib, apparently. Okay. So, caution for a patient that is in shock, hypotensive, or in respiratory depression. Have prolonged QT intervals. Remember, we were talking about the Q to the T and how if that's prolonged, some drugs can cause that. Some people even just have QT prolongation syndrome. Okay. You want to be careful with amiodarone when a patient has thyroid or pulmonary disease. Adverse effects related to changes in action potential. So it's affecting your cardiovascular, your cardiac output and your oxygenation and perfusion. The common adverse effects include nausea, vomiting, weakness, dizziness, and hypotension. And you can have bradycardia or atrioventricular blocks that could progress to heart failure. So on page 802, under cautions, contraindications and cautions, it talks about amiodarone, and caution should be used with amiodarone in patients with thyroid or pulmonary disease due to the risk of thyroid hormone abnormalities and pulmonary toxicity. Drug-to-drug interactions, we have digoxin again, so you probably don't want to give amiodarone and digoxin together, or amiodarone and quinidine together. You don't want to give amiodarone with antihistamines, phenothiazines, tricyclic antidepressants, and other specific drug-drug interactions with the individual drugs, which obviously aren't important. All right, so this just looks a little bit closer at amiodarone. So treatment of life-threatening ventricular arrhythmias. Amiodarone can also be given, so this is not the only indication, right, for amiodarone, because we said that it can treat atrial arrhythmias and ventricular arrhythmias. So when you're looking at this and it's talking about life-threatening ventricular arrhythmias, this means during a code. This means a patient that's in VFib, pulseless VTAC, and you're giving this during ACLS and a code, okay? But also, this is also an antiarrhythmic that can be given PO that this patient can take daily, once, twice a day, to control their AFib or AFib. Okay? Okay, any questions on the class 3? I feel like this is a lot. I could just see it on your face. Your poor face, you're just like, I can't do it. These classes are a lot. That's why I wanted to start with cardiac and not end with it. Okay? Because ending with cardiac, it's just too much information to process.
That's how we did last class, was we did cardiac last. Bit messed up.
Yeah, I know. I mean, obviously I didn't teach your class, but I taught my class in August. And I hated that cardiac was last. And I begged for it to be moved to week 1. Okay.
Do you have any recommendations on how to study this material?
Let me finish these couple slides and then we'll talk about that. Okay. All right. So class 4, block the movement of calcium ions across the cell membrane in cardiac and vascular smooth muscle. So who are our 2 calcium channel blockers that work on arrhythmias?
Verapamil and diltiazem.
Thank you. Verapamil and diltiazem, aka cardizem. I need you to know that. Okay? I need you to know that. These are calcium channel blockers that are specific for arrhythmias. Verapamil and cardizem. I've said it at least 10 times over the last 2 days. Okay? Maybe even more. I don't know. But, so this blocks the movement of calcium ions. Influx of calcium, it makes your cardiac contraction stronger. Okay? It makes your heart work harder. So if my heart is already working hard and having arrhythmias, we need to block that movement of calcium because it's causing trouble. It's causing too many issues. So we need to slow it down, block some of that calcium out so we can slow the conduction through the AV node, so we can slow the atrial fibrillation or slow the atrial flutter, so that we can actually have a normal functioning atria. Okay. Indications would be hypertension, treatment of angina, and treatment of rapid supraventricular dysrhythmias like AFib, A-flutter, and SVT. Oh, you want to be cautious in pregnancy and lactation. It is metabolized in the liver and excreted in the urine, so you want to be cautious with patients that have impaired renal or liver function. Just like everything else, there's CNS effects, GI effects. You have a risk for hypotension, heart failure, shock, arrhythmias. So if all of these drugs can lead to bradycardia and hypotension with CNS effects, what are our patients at risk for? False. This is a huge safety risk. Huge safety risk for all of these drugs. So drug-to-drug interaction, if your patient is on verapamil, you want to be careful with beta blockers, digoxin. If your patient is on diltiazem, you want to be careful with cyclosporines and other antihypertensive meds. So this is just taking a closer look at diltiazem. This is extended release preparation used to treat hypertension and angina in adults. Other preparations are used for angina and cardiac dysrhythmias, including rapid AFib, A-flutter, and paroxysmal supraventricular tachycardia, because it blocks the movement of calcium ions, which is going to slow the conduction from the SA node into the AV node, which is hopefully going to slow that atrial fibrillation and cause it to contract and relax normally. Okay. Your adverse effects are going to be your CNS, dizziness, lightheadedness, headache, symptoms of heart failure, peripheral edema, cardiovascular, bradycardia, and AV blocks, flushing due to vasodilation. Okay, remember I said when you have massive vasodilation, you have flushing, your skin turns red because all the blood is going to the surface. Nausea and hepatic injuries. You want to be careful with hepatic toxicity. So which of the following is an adverse effect of the class 2 antiarrhythmic? So what was our class 2?
Treatment for atrial fibrillations.
What drug? Or drugs?
Are beta blockers?
On page 7.
Adenosine, so it would be A.
Adenosine and digoxin and propranolol. All of these drugs can cause bronchospasm because they're all affecting the beta receptors, and they can affect the beta 2 receptors, okay? Which is dangerous for who? What patients?
Patients
COPD.
with asthma and COPD.
Yes.
So bronchospasms.
Okay, so what is the best way to study for pharmacology? If I had the answer to that, I would be a very rich person. They have pharmacology apps that will quiz you. You can make your own pharmacology note cards. You can buy pharmacology note cards, which I remember doing in nursing school. The easiest way to learn drugs is by their classification. Okay, so it's easier to learn about ACE inhibitors as a whole than only learn about lisinopril. But it's also important to know that lisinopril is a common ACE inhibitor, right? So we're looking at the classifications of ACE inhibitors, knowing that they all end in pril, and knowing that the most common ACE inhibitor is lisinopril. Okay? So then when you're looking at ARBs, you want to learn about the entire classification of ARBs, knowing that they end in sartan, and a very common ARB is valsartan. Okay, so that you're learning all about the entire category. You're able to recognize it because of the, what is that called? Suffix, the end? Is that what suffix? The suffix of the word. And then you recognize your most common drug. Okay, so then when you're thinking about calcium channel blockers, you know that there's two special ones, but the rest of them end in dipene. Okay, so calcium channel blockers are going to block the calcium. We know the calcium makes that contraction harder and stronger. If it's too much, it's too hard, things are going too intensely, we need to back off on that calcium. So that calcium channel blocker is going to block that really intensity of those calcium channels. Okay, but then we have those two outliers, those zebras, that work more for arrhythmias. And we need to remember those because they don't end in dipene. They're verapamil and cardizem. So that in that situation, you have to recognize the individual drugs because they're zebras. Okay? So then when we're talking about class 2 antiarrhythmias, we want to make sure we know digoxin. And we want to make sure because that's our big zebra. Digoxin is a huge zebra. I told you this is a classic NCLEX drug. Knowing the therapeutic level, knowing the signs and symptoms of dig toxicity, knowing the treatment of dig toxicity, knowing what puts your patient at a higher risk of dig toxicity is going to be what? Hypokalemia. Okay? So it's truly looking at the category, knowing what is affecting all of those drugs, right? The whole category, being able to recognize what they end in, being able to recognize at least one common medication of those drugs, and knowing the zebras, the outliers. Does that help? Let's go to lunch. I'm hungry. The girl needs food. Does that help you guys at all?
Thank you.
Yeah, maybe.
Yeah, it's just a lot. You just gotta break them down, I guess.
I told you, this is a heavy month. It is heavy content. And we are just going to get through it together. Okay? So come back at 12.
I'm in my book. Thank you for getting me in.
You're welcome. Yeah, Justin should be working. If you don't have your books already, he's working on it. So
Well, I'm just
he's
letting
getting
you know
it.
that I'm in, so thank you.
Oh,
I
good,
appreciate
good,
it.
good, good. Okay. And then you guys that emailed me earlier, check to see if your books are on or ready or whatever. Okay.
Before you go, really quick, I was just wondering. I know that you said that you worked on a study guide, like a full things to know. But do you know when you will be able to get something out to us?
Girlfriend, it's gonna come when it comes. We have to be so thankful for what we get, right? So believe me, you will see it in your email and you will jump for joy when you see it.
Okay.
Okay?
What time should we be back?
12.
Okay, thank you.
Okie dokie. We're back. All right, on to chapter 46. Yes. Okay, so ASBCD means atherosclerotic cardiovascular disease. That is what that acronym stands for. Atherosclerotic cardiovascular disease. It is caused by an accumulation of cholesterol plaque in arteries and can lead to peripheral arterial disease, myocardial infarction, and ischemic stroke. Coronary artery disease is a type of atherosclerotic cardiovascular disease. Okay? So, in chapter 46, we're talking about anti-anginals. What does angina mean? Chest pain. So, coronary artery disease is a type of ASCVD characterized by progressive narrowing of the coronary arteries, leading to decreased delivery of oxygen to the cardiac muscle cells. This is a chronic disease that is managed but not curable. Atheromas are a type of fatty tumor that is in the endothelial lining of the arteries. And then angina pectoris is means suffocation of the chest. So this is chest pain, pectoris, like pectoral muscles. So word for chest pain. Literally. Okay, so this shows atheromatosis plaque and thrombosis of the atherosclerotic plaque. So this is your plaque building up, okay? Do you think plaque is sticky? Yeah. So when your little platelets are swimming by and they get stuck like a fly trap, stuck onto that fatty plaque, and then what do platelets do? What do they do with each other?
Stick to each other?
Aggregating. I use the word aggregate on purpose because there's drugs called antiplatelet aggregators. Okay? So I'm using the word aggregate for a reason. So your platelets, something gets stuck, and then they're like, ooh, I want my breasts over here. And they go and stick with them, and then they stick and stick and stick and stick and stick until, boom, a blood clot forms. Okay? So, we take antiplatelet aggregators like Plavix, aka clopidogrel, so that this aggregation and accumulation does not occur. Okay? So, this is a fatty atheroma. This is plaque that has sticky platelets surrounding it and forming a clot. Okay? Angina is pain in response to lack of oxygen in the heart muscle. You must know the difference between stable angina, unstable angina, and Prince-Metal angina. You must be able to distinguish between all three. So, stable angina, what happened? Oh, can you guys see my screen? It just went out for a second. Okay.
Yeah.
Stable angina is no damage to the heart muscle. Let me know if I start going in and out because I'm not connected to my hotspot. Basic reflexes surrounding the pain restore blood flow. So stable, it's just happening. Okay. There is no impending doom. There is no impending risk of MI in this moment because it is stable. And we are going to learn the characteristics of each of these. Unstable angina is episodes of ischemia, which is tissue death, occurring even when at rest. Okay.
Do you mean that the patient doesn't feel that impending doom with stable?
Not necessarily. That's a good question. I more so meant stable angina is not usually a precursor to an MI. That's more what I meant. Thanks for asking. Prince-Metal angina seems to be caused by spasming of the blood vessels and not just by vessel narrowing. An acute MI. So this is coronary vessels become completely occluded and is unable to deliver blood to the cardiac muscle. We talked about this a lot yesterday. So those coronary arteries that wrap around the heart are constantly feeding that muscle tissue blood and oxygen. Okay. So if at any moment that gets cut off, blocked in any way, you are at risk for an MI. Okay. So the area of muscle that depends on that vessel, and remember, they all feed a different part of that heart muscle. Some of them feed the atria, some of them feed the ventricles, some of them feed both sides. There's one that wraps around, the circumferential artery wraps around. The pain can be excruciating. A lot of symptoms, a lot of times people have really intense nausea, vomiting, which is a severe sympathetic stress reaction. Excuse me. And this is serious. This is obvious. I mean, we all know how serious an MI can be, right? So arrhythmias can develop in nearby ischemia because one of the reasons for arrhythmias is decreased oxygenation to the myocardial cells, right? So if you have decreased oxygenation to a part of the heart, that can cause a fatal arrhythmia, like VTAC with no pulse or VFib. Okay, or VTAC that goes into being pulseless. So most of the deaths that are caused by an MI are a result of a fatal arrhythmia. My father-in-law had a massive MI at the kitchen table. My poor husband did CPR on him until the ambulance came. VFib when the ambulance 2 shocks. But ultimately, he passed in the emergency room. And it was really, really super sad. And my husband still, even 5 years ago, this was 5 years ago, still, lives with this every day. But it's important to know that that decrease in oxygenation to the myocardial cells is a huge risk factor for arrhythmias. Okay. So anti-anginal agents help restore appropriate supply and demand ratio in oxygen delivery. So what's happening with angina? The vessels, the coronary arteries are narrowed. It's not getting enough oxygen to the myocardial cells. So what do we need to do?
I need to open.
They need to open. What do we call that? Vasodilation, right? We need to vasodilate. So we're talking about drugs that cause vasodilation. What was a drug that we talked about yesterday that you can take 3 times in a row every 3 to 5 minutes? Nitroglycerin.
Nitroglycerin.
Yes. So people that have stable angina, those are the ones that have a little pill bottle in their pocket or in their medicine cabinet or in their car because they know it's coming and they have treatment because they need to vasodilate. Okay? So you improve the blood delivery to the heart muscle in one of 2 ways, by dilating the blood vessels and by decreasing the workload of the heart. Each are effective, all are effective, and may be used in combination. Drug choice is determined by the tolerance of the adverse effects because, like we said yesterday, it's all about the risk versus the benefit of the drug. So, interaction of anti-anginal agents with factors affecting myocardial oxygen demand. So, this talks about your different drugs. Okay. So, this is your negative feedback system. Decrease in myocardial oxygen consumption. Hold on. Wait a second, I think I said that wrong. Okay, so these are the ways that the drugs are lowering your heart's need for more oxygen. Okay, so beta blockers and calcium channel blockers are reducing the workload by reducing the heart rate. If you reduce the heart rate and the workload, the heart muscle doesn't need as much oxygen. Beta blockers, nitrates, and calcium channel blockers reduce the blood volume by reducing the preload, right? Not the afterload, the preload, okay? And this lowers the oxygen consumption that those heart muscles or heart cells need. Beta blockers, nitrates, and calcium channel blockers also decrease your afterload. So it's working pre and post, okay? And then they also can decrease the left ventricular muscle size. This happens over time. Okay. So remember, the more you work a muscle, the bigger it gets, causing hypertrophy. So if that takes time, then a decrease in left ventricular muscle size is also going to take time. Okay. This is not something you were like, oh, I take metoprolol and my left ventricle is the size it should be. No. Okay. And then beta blockers and calcium channel blockers decrease muscle contractility. So remember that influx of calcium causes really strong contractions. So if we're blocking the calcium, we're decreasing muscle contractility. Okay. Okay, so there's 3 nitrates. Isosorbide dinitrate, which is isosortal. This is a common one. Isosorbide monotrate is a little less common, but you see it. And then nitroglycerin also, I can't talk, is obviously the most common vasodilator. Okay, that's the one we all identify, the easiest. I got a couple stars coming up. So therapeutic actions, they act directly on smooth muscle to cause relaxation and depress muscle tone. Relax and dilate veins, arteries, and capillaries. The main effect seems to be related to drop in blood pressure. Why? What causes your drop in blood pressure?
Dilation.
Vasodilation. Vasodilation. Vasoconstriction is going to raise your blood pressure. Vasodilation is going to lower your blood pressure. So indications is the prevention and treatment of attacks of angina. Excuse me. This is rapidly absorbed, metabolized in the liver, excreted in the urine. So we automatically know that this is hepatotoxic and nephrotoxic. I would assume you don't really want to vasodilate your baby in utero. That doesn't sound like a good idea. Contraindications would of course be allergies, severe anemia, and a head trauma or cerebral hemorrhage. Why?
Because they already have less, or they already don't have like blood. They don't have a lot of blood with like anemia. It has to do with oxygen or no?
So if we're talking about anemia, yeah, that definitely has to do with oxygen consumption. Because
Would
if
it
you have less
increase?
oxygen carrying capability, because the fact that you don't have enough red blood cells, you need to correct that problem. Okay. When we're talking about head trauma or cerebral hemorrhage, the last thing I want to do is vasodilate. That is just asking for your patient to bleed out and die. Okay. Falls isn't wrong, but it's more about if your patient is having if they're in hypovolemic shock because of bleeding out, the last thing you want to do is vasodilate, you want to vasoconstrict. Because if you're bleeding out, you're hypovolemic, your blood pressure is in the toilet. You're extremely hypotensive. Okay. Cautions, we already talked about hepatic or renal disease, pregnancy and lactation. And then you don't want to use this in hypotension, hypovolemia, and conditions that limit cardiac output. The thing about the head trauma is on page 815. And it just talks about head trauma or cerebral hemorrhage because of the relaxation of cerebral vessels could cause an intracranial bleed. And that has a star next to it. On page 816, it talks about nitro and how it's given, how often it's given. We already talked about that nitroglycerin is a sublingual tab. It is not to be swallowed. It is not to be chewed. That will change the absorption of the drug. On page 818, it talks about protecting nitroglycerin from light. Have you ever seen a bottle of nitroglycerin? It's in a brown bottle, a brown opaque bottle. Opaque meaning you can't see through it. Okay, so you have to protect nitroglycerin from light because it decreases the amount of the drug in the pill, in the sublingual pill. So it changes kinetics. And then again, it can be given every 5 minutes in 3 consecutive doses. It is important for you to know the things that I just said about nitroglycerin. Adverse effects are related to the vasodilation and decrease in blood flow. So that's where you're going to get your CNS effects that include your dizziness, weakness, fatigue, safety risk, huge risk for falls. Because if we're massively vasodilating and we become extremely hypotensive, we are going to have less oxygenation to our brain. Skin-related effects. What did I say happens to your skin when you vasodilate? It gets red. Why? What do we call that? Flushing. Thank you. Perfect. Okay, let's talk about the types of angina. They're on page 812. I'm sorry to bounce around, but I don't want to forget to talk about it. So if you would go to page 812, it says that stable angina, there, like we said on the PowerPoint, there's no damage to the heart muscle, and the basic reflexes surrounding the pain restore blood flow to the heart muscle. This process can go on for a long time with no resultant myocardial infarction. This is called chronic angina, and this condition can severely limit a person's activities and quality of life. When we're talking about unstable angina, there is no damage to the heart, bless you. But the person is at increased risk of a complete blockage or blood supply to the heart muscle if the heart needs to work harder or the oxygen demand increases. So this person needs to sit and rest. The person with Prinzmetal angina has page 812 has angina at rest. Listen to what I'm saying. It is often at the same time each day, and usually with an associated electrocardiogram pattern change. So remember, when we were talking about the Prinzmetal angina, we said that it was a spasm of the coronary arteries. The key characteristic of this type of angina is that it occurs at the same time every day, even at rest. Okay? So knowing those differences on page 812 between all three different types of angina is going to be very important. The patient asks the nurse to explain the type of angina they are experiencing. They are experiencing angina at rest, often at the same time each day. What type of angina is the patient most likely experiencing?
B.
Prinzmetal. B. Yay. All right, so we are finally getting into beta blockers. Your most common beta blocker on this list is metoprolol, also called Lopressor. Atenolol, which is tenormin, is also common. Propranolol, also known mostly by Inderal, is also common. This medication can also help treat anxiety. So if you're a younger human and you've taken propranolol, it was most likely for anxiety purposes. And I hear that it is actually very helpful. Therapeutic actions, we have competitively blocks beta adrenergic receptors in the heart and juxtaglomerular apparatus. So where are we?
Kidneys.
Kidneys, thank you. So this decreases the influence of the sympathetic nervous system on these tissues. What is the sympathetic nervous system? Fight or flight. So this decreases that influences, which is why propranolol helps with anxiety. Because when we feel anxiety, we feel that fight or flight inside when we don't need to. Okay. So indications is long-term management of angina pectoris caused by atherosclerosis, sometimes used in combination with nitrates to increase exercise tolerance. Propranolol and metoprolol can also be used to prevent reinfarction. So a patient that's already had an MI, but is stable 1 to 4 weeks after an MI. I'm going to sneeze, I know it. Woo!
God bless you.
Thank you. Okay. They're absorbed from the GI tract undergo hepatic metabolism excreted in the urine. Propranolol, it increases its bioavailability of drug that works. So if you take this with food, it helps it work better in your body. Contraindications would be bradycardia, so a heart rate less than 60, a heart block or shock. You want to use caution in patients with diabetes, peripheral vascular disease, asthma, COPD, and thyrotoxicosis. Why asthma and COPD? Well, say it louder.
Because it's a beta blocker?
So it is a beta adrenergic blocker, which means it's non-selective. It works on beta 1 and beta 2. Beta 2 to lungs. So that means it can cause bronchoconstriction in a patient that has asthma or COPD, which if those patients have bronchoconstriction, they then have respiratory distress because they're more at risk for respiratory distress. Excuse me. Adverse effects associated with the blockade of sympathetic nervous system, so your fight or flight. The dose is used to prevent angina is lower than the use to treat hypertension. So this means that you could be on 12.5 milligrams of metoprolol for angina, but if you were on metoprolol for hypertension, it's probably like 100 milligrams, okay? CNS effects, I feel like you should know this by now. Do I have to say it again? Okay. GI effects, respiratory effects, constriction, okay? Decreased malaise, feeling of badness. You just feel like shit. Excuse my language. Drug-drug interactions, you really don't want to take these with NSAIDs. Epinephrine, alkaloids, or insulin or anti-diabetic agents, which is crazy because most diabetics have heart conditions. That most of them take metoprolol. So, do they have interactions? Yes. In these patients, is the benefit greater than the risk? Yes. Okay. So when you go to clinical and you're like, oh my God, I'm giving 5 units of insulin, but I also have metoprolol ordered. So this is looking closer at metoprolol. This is the treatment of stable angina, also used for treatment of hypertension, prevention of reinfarction of MI, and treatment of stable and symptomatic heart failure. Also add on to that list, it can be used for rate control for AFib and A-flutter. Adverse effects include your CNS effects, your cardiovascular effects, your GI effects, your impotence. Guess what impotence causes? Non-compliance. All of a sudden, bro can't get it up, and he's like, I'm not taking it anymore. And then he goes back and Dave. So what's important when it comes to stuff like that? For you as the nurse to do for your patient?
Education.
Educate. Patient education, yes. We are moving on to calcium channel blockers. Rochelle, January.
Yes.
Do you remember what beta blockers can mask?
Symptoms for hypoglycemia.
Ah, yes, I need you to know that. Beta blockers can mask the symptoms of hypoglycemia. See, I had her 3 months ago and she still remembers it. I knew she was going to remember it because I made her look for it for like an extended period of time. She gave me multiple answers. And then I was like, all right, you tried enough. I'll give you the answer. All right, so we are going back to calcium channel blockers. The one thing that I really don't enjoy the way that they cover all of this is they just jump from classification to classification, and they're doing it based on the pathophysiology. When in reality, calcium channel blockers can be for hypertension, they can be for antiarrhythmia, they can be for angina, they can be used for all of these things. Why not say it once instead of covering it 3-4 times in every pathophysiology? You know, I don't get it.
Because a lot of these, the calcium channel blockers and the beta blockers are also used to treat migraines, aren't they?
I can see that.
Like propranolol and verapamil, I think. I'm pretty sure that
Yeah.
those are also used to treat migraines.
So a lot of drugs have something called an off-label use, where they have found that for some reason, it treats a different thing that has absolutely nothing to do with cardiac, like propranolol. It is helpful for patients with anxiety. They found that out because when they were doing trials for propranolol, they found that they had decreased anxiety levels in their trial patients. So it became an off-label use for propranolol. So if they are used for migraines, it's most likely the same thing where they found that it can be used for that off-label use. So like we've talked about many a times, our calcium channel blockers end in dipene, except for two, which is our verapamil and our diltiazem. You have two main types. The non-dihydropyridine is your outliers, your zebras, okay, which are more dangerous to use for patients with heart failure. Your we've talked about this multiple times, that calcium channel blockers inhibit the movement of calcium ions. So I guess if you think about it, the way that they keep talking about the same things over and over again is just reminding you over and over and over again what they are. So I guess repetitory things can't be the worst thing. So your indications for this specific pathology is Prinzmental angina, chronic angina, effort-associated angina, and hypertension. So this is generally well absorbed after oral administration. It's metabolized in the liver, excreted in the urine. So we are talking about hepatotoxicity and nephrotoxicity. We have an onset of 20 minutes with a duration of 2 to 4 hours. So it lasts a little while. We're not giving this to babies because it is contraindicated in pregnancy or lactation. Remember, we've said this multiple times, that we're using caution with patients and heart. We've also talked about this many a times. It's the adverse effects are related to the effects of the cardiac output and on smooth muscle. So we can have our CNS effects, GI, cardiovascular, and our skin effects. And drug-to-drug interactions vary with each of them. And what did we say we couldn't drink? Grapefruit juice. True or false? The adverse effects of calcium channel blockers are related to their blockade of the sympathetic nervous system.
False.
False. Tis false. The adverse effects of beta blockers are related to their blockade of the sympathetic nervous system. The adverse effects of calcium channel blockers are related to the effects on cardiac output and smooth muscling. We have a couple drugs in this category. Renexa is common. It's a common medication. It's effective in treating angina. Added benefits decreases blood glucose levels in diabetic patients. So, you know, when you see commercials for drugs and they're like, may lower your blood sugar if you have type 2 diabetes, right? Decreasing incidence of VFib, AFib, and bradycardia in patients with chronic angina. That's nice. So it seems like it has some protective properties, Renexa. The therapeutic actions, the mechanism is not completely understood. It may inhibit late sodium influx, decrease in myocardial workload. It's just a scary thing to say, though. We don't know. We made this. We made a human take it, and then all of a sudden, this is what happened, and we're like, cool, let's use it. But we don't know how, or what, or where, or when, but you should take this every day. Okay. So, indications, this is the first line treatment for angina. It's also used in combination with nitrates, beta blockers, or amlodipine. What is amlodipine? What classification of drug is this?
Calcium channel blocker.
Calcium channel blocker.
Calcium channel blockers, because calcium channel blockers end in dipine. Pharmacokinetics are rapidly absorbed, metabolized in the liver, excreted in the urine and feces. Contraindications are a known sensitivity. Pre-existing prolonged QT intervals. Pre-existing prolonged I don't see any pens. Pre-existing prolonged QT intervals. Okay. In combination with drugs that would prolong QT interval. Who remembers what drug that is? Or knows what it is? Really?
Is it lidocaine?
Ah, no. That's a good guess, though. That's a good
Digoxin?
guess. No. It is a very common medication that we've probably all taken for nausea. Zofran. Zofran. One of its biggest adverse effects is prolonged QT intervals. Very important to remember. These drugs have drug-to-drug interactions, including digoxin, tricyclic antidepressants, antipsychotics, and grapefruit juice. I don't even know why they make grapefruit juice. First of all, who drinks grapefruit juice? That sounds horrific.
That's funny. My dad actually used to drink grapefruit juice.
Did he
Like, all
have
the
to
time.
stop drinking it because of a medication? Because it's almost contraindicated in every single medication ever.
Yeah, he doesn't drink it anymore. No.
I would be curious to know if it was because of a medication interaction that he can't drink it anymore. You ask him that and you tell me.
He actually has a lot of heart problems, so it most likely.
What time were you here? 2:30. 2:30.
It's Jessica.
Yeah.
Did you by chance turn your transcript off? Because mine isn't generating for you when you talk anymore.
Me either.
Ooh.
Mine isn't either.
Uh-oh. It's let me hit resume. Oh. I don't know. But I will tell you that the recording from yesterday is finalized and it's currently downloading on my computer in my office, and I'll have it sent out to you at our next break. So this one, I'm hoping doesn't take, 24 freaking hours. It usually doesn't. It never takes that long. So I don't know what the problem is. Maybe I should leave and come back, but I don't want to screw anything up. Do you guys, is it really important? Would you really like it to come back? Yeah.
I just miss something sometimes when you're talking about. I just look at that and then I can like get what it was without
That's a good
interrupting.
point. Okay. Oh, there it goes. Do you see it? Okay.
Yes, ma'am.
Awesome. All right. All right, chapter 47. Lipid lowering agents. We are not going to spend a ton of time on this chapter.
Miss Simmons,
Yeah,
you have to share your screen.
I know, I'm opening it.
Oh, okay, sorry.
It's okay. Okie dokie. Clinical aspects of metabolic syndrome. Let me get to the chapter. One, two, three. I only have 3 important things to say in this entire PowerPoint. So I am going to fly through it a little bit.
I'm sorry. Which chapter are we on now?
37. So, clinical aspects of metabolic syndrome. Insulin resistance is a fasting blood sugar equal or greater to 100. So that is a diagnostic tool for insulin resistance. Abdominal obesity is when the waist measurement is greater than 40 inches in males and greater than 35 inches in females. Lipid abnormalities, so your cholesterol, your HDL is greater than 40 in males, greater than 50 in females, and any triglyceride levels less than or equal to, no, greater than or equal to 150. I hate the little.
So do I. Me too. She always gets me.
Oh. Okay, so this is greater than. So greater than, greater than, greater than. So then this is less than. So HDL less than 40 in males, less than 50 in females, and then triglyceride levels greater than 150. Because I do know that you don't want your triglycerides greater than 150. You want your blood pressure less than or equal to 130/85. When you have a pro-inflammatory state, you have increased, macrophages, increased level of interleukins and tumor necrosis factor. These are all part of your inflammatory process, which we will get to. And prothrombotic state, which is increased plasminogen activator levels. This causes increased clotting. Okay.
So unmodifiable risk factors for atherosclerotic cardiovascular disease is genetic predispositions, age, and sex. So a lot of people, they get diagnosed with high cholesterol and they're like, oh my God, what am I eating? I don't even eat that bad. And it's because a huge part of hyperlipidemia, or also called hypercholesteremia, is family history. Okay, genetics plays a huge part in high cholesterol. Modifiable risk factors include gout, cigarettes, sedentary lifestyle, unhealthy diet, high stress levels, hypertension, high blood cholesterol levels. So what do you want your total cholesterol to be less than? So close, 200. You want your total cholesterol to be less than 200. Obesity, diabetes, and then other factors that, if untreated, may contribute to atherosclerotic cardiovascular disease. Metabolism of fats in the body. So this just shows you where and how they metabolize. So dietary fats, everything starts in your mouth. Saliva helps break down food. Okay, we have special enzymes in our saliva that starts breaking down fats, proteins, and carbohydrates. Okay, obviously your stomach, we have lots of hydrochloric acid, we got a lot of stuff going on down there, in there, and that is where a lot of our digestion occurs. We go into the small intestine, where everything is really liquid and gross, and that is what we call chyme, C-H-Y-M-E, chyme. Is the yucky poo that is stuck in your small intestine. Okay. The gallbladder helps a lot with fat metabolism. Who doesn't have a gallbladder? Who poops like crazy because they don't have a gallbladder? Yeah. Every person that gets their gallbladder removed, it's like every time they eat, they have to poop.
Not me.
Lucky that. What'd you say?
Not me. It didn't change a single thing for me. My husband, on the other hand, it did. My mom and I, it didn't change one thing.
Well, hopefully you're not on the other one
We're the
and
zebras.
constipated. You're the zebras. Good job. And then we jump over to 5. Bile is recycled in the liver. Bile lives in the gallbladder and the liver. And the reason we have to get our gallbladder removed is because sometimes we have gallstones, we have blocked bile ducts, we have all these things that interfere with the release of bile, okay? Bile breaks fat into, I don't know what that says, micelles? Yeah, micelles absorbed into the small intestine wall, and they are also absorbed into the lymphatic system. So for the heart, fats enter circulation, reach periphery, and are stored as fat. We can use them as energy absorbed into circulation. You can have atheromas develop, which is those fatty tumors in the arterial walls, right? They can injure the vessel, make the vessel inflamed, and then when you have plaques in your arteries, that can also cause aggregation of your platelets. Okay, so lipoproteins that are produced in the liver, intermediate density lipoproteins is IDLs, low density lipoproteins, LDLs, high density lipoproteins, HDL. We are most familiar with HDL and LDL because when they run our cholesterol, it's usually a total cholesterol, your triglycerides, and then your high and low density, okay? So there's a good one, and then there's a bad one. HDL is thought to play a protective role against the development of atherosclerosis. It is known that HDL levels increase during exercise, which could explain why people who exercise regularly lower their risk for atherosclerotic cardiovascular disease. That's on page 831. So you want a higher level of HDL. HDL is the good cholesterol. LDL is the bad cholesterol. Cholesterol is the base unit for formation of steroid hormones. That's just basically the definition of it. Diet high in saturated fat increases cholesterol production in the liver. This is what leads to fatty liver disease, right? If your liver is metabolizing all of this fat, it gets caught all inside the liver, causing your liver to be fatty. The fatty liver disease is a legitimate disease pathophysiology. So hyperlipidemia is high levels of lipids in the blood. It's caused by excessive dietary intake and then genetic alterations in fat metabolism. So there's something about the patient's genetics that is causing the metabolism of fat to be decreased. Dietary modifications are usually a successful treatment, and then drug therapy needed if the cause is genetically linked and the lipid levels from dietary limits do not decrease. Low density lipoproteins are loosely packed fats, true or false?
False.
Trying to find where it says it. But it is going to give us a rational. False. LDLs are tightly packed fats that are thought to contribute to the development of ASCVD. So HDLs are lightly packed, so not tight, which is why they're the good cholesterol and not the bad. Okay. Lipid lowering agents, they lower serum levels of cholesterol and various lipids. We have a couple different types of drugs. Bile acid sequestrants, which there's going to be something very important for you to know about that. HMG-CoA reductase inhibitors, which is your statins. Cholesterol absorption inhibitors, PCSK9 inhibitors, and then others that do not fall into these classes. So, bile acid sequestrants. These are used to decrease plasma cholesterol levels, and there's 3 currently in use. The only one I've ever seen is cholestyramine, and this, let me find it. Is there something important? We're gonna get to it. So it binds with bile acids in the intestine to form insoluble complex that is excreted in the feces. The indication is to reduce the serum cholesterol in patients with primary hypercholesterolemia, in adjunct to diet and exercise. So cholestyramine is the treatment, can be used for treatment pruritus associated with partial biliary obstruction. If you have ever known someone that has biliary obstruction during pregnancy, where they have that like really intense itching, it can be used for that too. Pharmacokinetics, it is not absorbed systemically. It acts while in the intestine. So it binds with bile acids and then it is excreted in the feces. So it bulks all your fats up in your intestines and then you poop it out. Okay. Contraindications would be a complete biliary obstruction or an abnormal intestinal function. So if there's something wrong with your intestines, they probably won't give you something like this. And this is the least risky choice during pregnancy. You're using it with caution. It is not contraindicated. We're just being cautious. Okay. What are fat soluble? There's 4 of them. A, D, E, and K. So if bile acid sequestriants bind to the fat in your intestines, and vitamin A and E need to have fat because they are fat soluble vitamins, what do you think would happen if you were to take this and you're not intaking enough fat soluble vitamins?
You're going to be deficient in those vitamins.
Deficiencies. That is very important. You will have, if you take bile sequestrant, bile acid sequestrants, you are at a very high risk for decreased absorption of fat soluble vitamins, which include vitamins A, D, E, and K.
I'm sorry, I'm just trying to understand it. So you said when you take those, you're at risk for deficiencies in vitamins A and E because they're also fat soluble vitamins.
Right. But this is only listing E and E. I'm telling you that there are 4 fat soluble vitamins, which include A, D, E, and vitamin K. So I would like you to know all 4. The next very important thing that I would like you to know is that we have drug-to-drug interactions. We just said this with fat-soluble vitamins. Thiazide, diuretics, digoxin, warfarin, thyroid hormones. Hormonal contraceptives. What do we need to do if your patient is taking this and she is within childbearing years? Huh? Educate. Hey, girlfriend, your birth control is probably not going to work. You need a secondary form of contraceptives if you don't want to get pregnant. Okay. Also, has an interaction with corticosteroids. So, what page is this on? It is on page something very specific that I want you to know. Is on page 838. Consequently, any of these drugs should be taken 1 hour before or 4 to 6 hours after bile acid sequestrant. Contraceptive methods other than oral medication should be used to prevent pregnancy. If a person is pregnant and taking a bile acid sequestrant, extra fat soluble vitamins may be indicated. So I just told you 3 very important things. Okay, so if you are taking any of these drugs, you are not going to take them within 1 hour of a bile acid sequestrant or 4 to 6 hours after a bile acid sequestrant. I need you to know that.
What page would this be on in the book?
That is on page 838. $834. Do you not have it, the 9th edition? Oh, I probably don't. Oh, what edition do you have? Is it the 10th or the 8th? I do have. Is it because it's online? Oh,
Yeah.
I don't know.
Because
Is it the same for you?
I'm trying to find it. It's under.
In my book, it's on page 838, right above the prototype summary of cholestyramine.
It's under clinical or yeah.
It's on, so online. Ooh, so that sucks. Okay, so some of your page numbers might be off because you have an online book. I didn't know that.
But if you type in like 837 at the bottom where you told us to go and you scroll up, it just like the pages are longer.
Oh, the pages are longer. Okay.
Yeah, it's under clinically important drug interactions.
Yeah. Cool. So in my book, it starts on page 834, but then they have this big table, table 47.3, that takes up 835 all the way to 838. So I have this gigantic table that takes up 2 pages, and then the paragraph continues from 834. So I wonder if that's why. So they're saying that online it's on page 834. So I think it might just look a little bit different, but the information is exactly the same. Okay, so these are your HMG.
Is it the paragraph or is it drugs in focus?
It's in the paragraph that is titled Clinically Important Drug to Drug Interactions, which starts on page 834.
Okay,
But for me, in the book, it ends on 838 because it has a gigantic table that takes up 2 pages. So I don't know if online that's like to the side or something, but
right after.
you do. Okay. All right. So anyways, these are your statins. Your most common statin, which is Lipitor. Pravastatin, you'll see once in a while. Rosuvastatin, you'll see. Simvastatin, you'll definitely see. The other ones, not so much. Rosuvastatin, also known as Crestor, that's a very popular medication, just like Lipitor. So these drugs block the HMG CoA forming completing synthesis of cholesterol. So it interferes with the synthesis of fat to cholesterol. Okay. You want to use this in adjunct to diet and exercise, and it is used to treat increased cholesterol, triglycerides, and LDL, which is the bad cholesterol. This slows the progression of atherosclerotic cardiovascular disease, and it assists with the prevention of MI, stroke, revascularization procedures in patients with multiple ASCVD risk. It is absorbed from the GI tract. It undergoes a first pass in the metabolism, and then it is excreted through the urine. Just for your knowledge, I want you to look up what a first pass metabolism in the liver means. This isn't the only drug that does this, and it does not give a definition in the pharmacokinetics in the book. But I feel like it's something that I studied for my NCLEX. It's not imperative for this class, but I do want you to know what it means. Okay. This is contraindicated in active liver disease because of that first pass metabolism in the liver. So you want to use with caution for a patient with a history of or current chronic liver impairment, renal impairment because it is excreted in the urine. We have hepatotoxicity. Have you seen this word yet? But not yet from me. So what am I calling this? This is a zebra. This is a big fat zebra. Rhabdomyolysis. Rhabdomyolysis is a huge risk for statins. Okay. So on page 841, I don't know if it's the same for you, but on page 841 under adverse effects, myopathy, which is muscle pain, is a common side effect. Rhabdomyolysis, which is a breakdown of muscles with waste products that can injure the glomerulus and cause acute renal failure, is not common, but is a very serious complication of which nurses should be aware. There is an increased risk of rhabdomyolysis in older patients, those with low body weight, and those with hypothyroidism. Okay? So when it comes to statins, it's very common for your patients to have leg pain. And this causes them to be non-compliant. People don't like adverse effects that affect their daily activity, right? So my mother-in-law specifically was put on Lipitor. She complained of leg pain every day for 3 months. Okay? So what is the difference between regular leg pain and rhabdomyolysis?
Rhabdomyolysis, the muscle is breaking down.
The muscle is breaking down. And what did I say about proteins in the glomerulus? Protein molecules are big. They're big. They're some of the biggest molecules we have in our bodies. And when they go through the filtration system of our glomeruli, they injure the glomerulus, which can cause your patient to have an AKI, can cause injury to the kidney function, the glomeruli. Okay. So not only do you have muscle wasting, you have toxic buildup from that muscle wasting, which then leads to, because it has to be excreted somewhere, kidney damage in the glomerulus. So rhabdomyolysis is not just leg pain that we're complaining about. This is really bad leg pain. This is your kidney function is decreasing. Your creatinine is going up. Your urine output is lower. You're having, your urine all of a sudden is brown. Maybe you have blood in the urine from the And another thing that statins put patients at risk for is cataracts. This is another group of drugs. Grapefruit juice. That damn grapefruit juice. Nobody can enjoy it anymore. What would cause a drug-to-drug interaction with bile acid sequestrants? Why?
Thyroid hormones.
Why? Huh? Yes. So, what are our dietary recommendations for bile acid sequestrants when you're taking these drugs?
An hour before, 6 hours after.
1 hour before or 4 to 6 hours after taking a bile acid sequestrant. I do not need you to know anything about this drug. It is not a common medication. Yeah, I'm not gonna spend time on it, and I hope you're okay with that. I also don't care about these words. They're very uncommon. You're not going to see them often unless you work in a very specific area. You can look at them on your own time. I think the only thing that you would even think about would be important would be on the adverse effects, which injection site reactions and risk of infections. Other lipid lowering agents, fenofibrate. This increases lipolysis and elimination of triglycerides. Lipolysis. What does lysis mean?
Destroy or kill.
Breakdown, destruction. So this would be the breakdown or destruction of fats. Okay. So fenofibrate increases that breakdown or destruction of fats. So these are other lipid lowering agents that just helps the breakdown of fats. Vitamin B3, niacin, inhibits the release of free fatty acids from adipose tissue, increases the rate of triglyceride removal from plasma, generally reduces LDL and triglyceride levels, and may decrease levels of apoproteins needed to form chylomicrons. Big word. That has something to do with the metabolism in your liver. Okay, we talked, it was on a previous slide, but I'm not going to delve into it. But have you ever taken niacin? Anybody?
Seen somebody take it, it causes flushing and it makes you like tingle on your neck.
So, fun fact, my brother used to love smoking marijuana. Oh, still does. He's like almost 40 and he smokes every day. So anyways, back in the day, when my parents found out that my brother and his bestie were doing this, they were drug testing them every week. So if you take really large quantities of niacin, it can possibly help you flush things out of your system. And while doing that, it will cause serious skin flushing, where like you will become so red and itchy. And I literally remember him crying because of how red and itchy he was from taking so much niacin. And then they started making flush-free niacin that would potentially take away that risk of flushing and itching. But I will never forget that, and I thought it was hilarious. And I'm going to tell him later that I told all of you to stop. We're just going to finish this, and then we're going to take a break. Omega-3 fatty acids. I'm sure you've heard omega-3s are good for you. They're like a good fat. We have good fats, avocados and omega-3s that we get from salmon and things like that. So it inhibits the liver enzyme systems that decrease synthesis of triglycerides. So not all fats are made the same. Some are good, some are bad, some are really bad. Combination therapy. If your patient has shown no response to any of their dietary modification, their exercise or lifestyle changes, because they are one of those people that truly just has a terrible set of genetics and have high cholesterol because of those genetics, that's when they need to maybe do bile acids with niacin or statins with something else, okay? Care must be taken not to combine agents that raise the risk of rhabdomyolysis. Rhabdomyolysis will kill your kidneys. Okay, It is a very dangerous adverse effect. The nurse is caring for a patient taking HMG-CoA inhibitor. Which would be an appropriate intervention for this patient? First of all, what is a HMG-CoA inhibitor?
Statin.
The statin.
Statins, yes. So, what is our answer? I said it right after.
Monitor for adverse effects.
So the answer is B, arrange for periodic ophthalmic examinations. Why? Because statins increase your risk for cataracts. Cataracts. We might finish today, which means Monday will be all about reviewing and new content. So 10 minutes, and then let's get this done. Blood affecting coagulation, that's going to be in. Where's 49? We got a lot of stars in 48. Okay. Let's get this over with. All right. Chapter 48. Drugs affecting blood coagulation. Hemostasis is created by protective mechanisms to prevent excessive blood loss. So those, oh, I didn't share. There we go. So those protective mechanisms include vascular constriction, formation of the platelet plug, activation of the coagulation cascade, formation of a blood clot, and then the dysfunction of hemostasis is when we have a thrombosis, which is a blood clot we're not supposed to have, and then bleeding or hemorrhaging. Okay. So the coagulation cascade includes the intrinsic pathway, the extrinsic pathway, and the common clotting pathway. So this is the process of blood coagulation. So it starts with an injury to the blood vessel, which leads to blood vessel constriction, loss of blood into the tissues, platelet adhesion to the wall of the injured vessel, and platelet aggregation. Remember, I said we were going to talk about that word a lot, aggregation. And then we have the intrinsic pathway to clot formation and the extrinsic pathway to clot formation. So when you have an injury to a blood vessel, all of these things occur. Okay. So the intrinsic and extrinsic pathways all lead to blood clot formation. The platelet adhesion and platelet aggregation lead to a platelet plug. Okay, so it's like plugging the sink or the bathtub. Okay. Loss of blood into the tissues increases extravascular pressure, compression of the injured blood vessel. This is a bruise, a hematoma. Okay. And then blood vessel constriction leads to decreased blood flow at the site of injury. So if the vessel constricts, that means it's narrowed and smaller, so not as much blood is getting to the site of bleeding. Okay. And then all of these things decrease blood loss at the site of injury. Okay. So injury occurs. It cascades into the negative feedback system of boom, 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 which causes the dominoes to fall here, which causes decreased blood loss. Okay. So it's called a pathway because one thing leads to the next, leads to the next. Hey, what's up? Wait, let me call you back. I didn't know if it was, yeah, I'll call you right. Okay, no, you're fine. Oh my God, you're fine. Sorry. Okay, so this is just a picture showing you platelet aggregation and the formation of that plug. So here's the injury to your vessel. The platelets are adhering, and then platelets do what they do best, and they aggregate together. Throw some fibrin in there, which is one of your clotting factors, and that's how we get a platelet plug. So disorders affecting blood coagulation. You have thromboembolic disorders, which involve the formation of thrombi, resulting in decreased blood flow or total occlusion of a blood vessel. This results in hypoxia, anoxia, and necrosis. Hypoxia, decreased oxygenation. Anoxia, no oxygenation. Necrosis, dead. Dead. Okay. Hypoxia can lead to anoxia, which leads to necrosis. Okay. Then you have hemorrhagic disorders, which is excessive bleeding. It's less common than thromboembolic disorders. Hemorrhagic disorders are usually caused by missing a clotting factor. Okay. Something is missing in your clotting cascade. So you have antiplatelet agents that alter platelet aggregation and formation of the platelet plug. You have anticoagulants, which interfere with the clotting cascade and thrombin formation. And then you have thrombolytic agents, which break down the thrombus that has been formed by stimulating the plasmin system. So when you are talking about a patient on blood thinners, it's a very blanket statement when you have to realize that there are a lot of different ways to thin the blood or decrease clotting. Okay. Antiplatelet agents, your most common are going to be aspirin, clopidogrel, which is also Plavix. This one, very common after heart catheterizations, Brilinta. Brilinta is super common after you have stents placed because it is a very potent antiplatelet aggregator that stops platelets from aggregating on your brand new stent or brand new valve. And you have to be on Brilinta for 3 months before you can go have a CABG, a coronary artery bypass graft, because that stent has to mature. Therapeutic actions of antiplatelet agents. So these inhibit platelet adhesion and aggregation by blocking receptor sites on the platelet membrane. Basically, it makes them less sticky. It makes them less able to stick together and aggregate. Okay. The indications are to treat cardiovascular diseases prone to producing occluded vessels, maintenance of venous and arterial grafts, we just talked about with the CABG, prevent cerebrovascular occlusion. This is why we have our patients taking 81 milligrams of aspirin daily. It's in prevention of stroke, MI, DVT. Okay. Treat peripheral artery disease and adjuncts to thrombolytic therapy and treatment of an MI and prevention of reinfarction after an MI. So remember we talked about, oh my God, what drug was that we talked about that can be used 4 weeks after a stable patient MI? Oh, I don't remember. I need to go look or find it somewhere. So the choice of drug depends on the intended use and the patient tolerance of the adverse effects. They are generally well absorbed, highly bound to plasma proteins, metabolized in the liver and excreted in the urine, and they do tend to enter human milk. Contraindications are specific to each agent. You can take some of these when you're pregnant. I took aspirin for my entire pregnancy. Did you find it? It's propranolol and so beta blockers. So adjunct to thrombolytic therapy and treatment of MI, prevention of reinfarction after MI, just like the beta blockers, metoprolol and propranolol. Thank you for. So cautions, of course, are going to be bleeding, recent surgery, a closed head injury, pregnancy and lactation. Look, it says caution, not contraindication. And then other cautions specific to each agent. What are our signs of bleeding? If you were looking at a patient, you were assessing
blood
that
pressure.
patient for signs of bleeding.
Low blood pressure.
Frozen.
When your blood pressure is low.
Wait, hold on. I heard bleeding gums.
Bruising.
Low blood pressure.
Tiffany said low blood pressure.
Yeah, maybe low blood pressure. But that's like more, I'm talking about your some things that you can see right when you're looking at your patient, your signs of bleeding, your textbook
Your
signs of
skin
bleeding.
change.
Yes, hypotension is going to come at the end. So we have bleeding gums, petechiae. Do we know what petechiae is? Little red dots. You ever throw up so hard you have those little red dots on your face because you broke all the blood vessels in your face? Okay. GI bleed. Coffee ground emesis. Easily bruised. I feel like that's it. So these are your cardinal signs of bleeding. And you should know them. And you should know to assess for them when your patient is on any type of medication that disrupts their clotting. So adverse effects, of course, bleeding, headache, dizziness, weakness, GI distress. We can have a skin rash. This is taking a closer look at aspirin. Indications, reduction of the risk of death and MI in patients with chronic coronary artery disease, such as patients with a history of MI or unstable angina pectoris, or with chronic stable angina. Reduction of the risk of death and recurrent stroke in patients who have had an ischemic stroke or transient ischemic attack. Also indicated for those as analgesic and fever reducer. So you guys have all done your med lists for the last how many months at clinical? How many mechanisms of action does aspirin have? The mechanism of action is how it works. Where does it work? What does it do? What is it capable of? So it inhibits prostaglandin synthesis, resulting in inhibition of platelet aggregation. Number one, it's a platelet aggregator. It also says analgesic. So number two, analgesic. Number three, it's an antipyretic. It reduces your fever. Number four, aspirin is the original NSAID. Okay. So aspirin is also capable of reducing inflammation. It has 4 mechanisms of action. I would like you to know the symptoms of acute aspirin toxicity. And this is on page 860, 862. (862) talks about acute aspirin toxicity with hyperpnea, possibly leading to fever, coma, and cardiovascular collapse. What is the antidote for aspirin? What do you do when
Vitamin
someone
K.
No. What do you do when someone comes in with an aspirin overdose? It's okay to look it up. I don't expect you to know everything. We all have Google.
Sodium bicarbonate.
And what else can we give? Oh, that can bind with aspirin.
Can you do the activated charcoal?
Yes, thank you. So we have sodium bicarbonate and we also have activated charcoal. This is especially important in children. Kids get their grubby little hands on everything, and God forbid your child gets a hold of a bottle of aspirin. Aspirin is extremely dangerous to children. So it is so important that we are able to bind with the aspirin, with the activated charcoal, treat the toxicity with sodium bicarbonate, and hopefully get to them before anything horrible happens. What is the effect of an antiplatelet drug?
B.
E. Alters the formation of the platelet plug because it stops them from aggregating. All right, so now we're going into anticoagulants. So anticoagulants, your most common are going to be enoxaparin, which is Lovenox, heparin, warfarin, which is Coumadin, dabigatran, which is Pradaxa, rivaroxaban, which is Xarelto, apixaban, which is Eliquis. Those are going to be your most common anticoagulants. So these interfere with the normal cascade of events involved in the clotting process, and its specific actions vary by drug. So the indications vary by agent. So for example, warfarin maintains the state of anticoagulation in which the patient is susceptible to potentially dangerous clot formation. What do we have to do for patients on Coumadin?
Regular PT-INRs.
Watch their INR. They have to be within a therapeutic range for their INR, which is on the bottom of page 863. So your therapeutic range for INR is 2 to 3.5 for Coumadin. What is the antidote for warfarin? Vitamin K. Possibly FFP, yes, but vitamin K is the antidote for warfarin. Dabigatran reduces the risk of stroke and systemic embolism in patients with non-valvular AFib. Treats and prevents recurrence of DVT and PE. So that is Pradaxa. So one thing I also want you to know is the onset of heparin and warfarin. The onset of heparin is immediate, okay? Heparin is given IV, it is given sub-Q. The onset is immediate. The onset for warfarin is 3 days. So when you have your patient in an acute care hospital that has come in with a DVT or a PE, and they're on a titrated heparin drip, and then they have orders to start taking warfarin or Eliquis. This is called bridging. This is what we do for patients that need to go home on an oral anticoagulant. So they are bridged from heparin, which acts immediately, and then they are bridged to something PO like Coumadin or Eliquis or Pradaxa that they can take daily, and they can't walk around just injecting themselves with sub-Q heparin 3 times a day. Okay? So the reason we have to bridge from one to the other is because the onset for those PO drugs takes about 3 days to become therapeutic. And we can't just leave them without any anticoagulant for those 3 days when we already know they're at risk for DVT, stroke, and PE because they already have one. Okay? Contraindications would be an allergy, conditions, tendencies. Warfarin is contraindicated in pregnancy. What anticoagulant is okay for pregnancy? Do you know anyone that needed anticoagulation
Aspirin.
during pregnancy? Aspirin, yes, but I'm talking about first of all, aspirin is an antiplatelet activator. I'm talking about anticoagulant.
Heparin.
Heparin or Lovenox. So heparin or Lovenox is safe to use during pregnancy because some women have clotting factors that if they do not use an anticoagulant during their pregnancy, they have a very high risk of miscarriage. Adverse effects of anticoagulants, of course, is going to be bleeding. Heparin-induced thrombocytopenia. What is thrombocytopenia?
Low platelet count.
Low platelet count, yes. So when it comes to heparin, in that box on 863, table 48.2, your therapeutic range for your APTT, which is used for titrating heparin, is 1.5 to 2.5 times your baseline. So when you start a heparin drip, they're going to see what your baseline APTT is. PTs by themselves are no longer used. We either use a INR for Coumadin or APTT for heparin. But a normal therapeutic range for PT is 1.3 to 1. But I would want you to know the PTT.
I'm sorry,
and
did you say
INR.
that was 1.3 to 1.5 for heparin? Or the PTT, I'm sorry.
Yeah, and it's on the PT, just one T, is 1.3 to 1.5. A PTT is 1.5 to 2.5 times the baseline.
Thank you.
And the INR therapeutic range is 2 to 3.5. So heparin is for the prevention and treatment of venous thrombosis and PE, treatment of AFib with embolization, treatment of DIC, which is disseminating something coagulation. Oh, I forgot what the I is. Prevention of clotting in blood samples and heparin lock sets, adjunct in the treatment of MI and stroke. So this inhibits thrombus and clot production by blocking the conversion of prothrombin to thrombin, which means it interrupts the clotting cascade. What?
Intravascular.
Oh, intravascular. Thank you. I'm like disseminating intravascular coagulation. Okay. Thrombolytic agents. This is very, 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 very important. There's 3 of them: alteplase, reteplase, tenecteplase. They can be referred to as TNK, TPA, I need you to know the contraindications for thrombolytic therapy. What is a thrombolytic? A thrombolytic, lysis, lytic, is the destruction of a clot. So this is what we like to call a clot buster, okay? This is an extremely high-risk classification of drugs. You have to meet a very specific criteria to be able to have these drugs administered. Most of the time, 9 times out of 10, these drugs are used for an ischemic stroke. They can be used for an MI. More common for an ischemic stroke, less common for an MI. I am going to give you a list of contraindications for thrombolytic therapy that I need you to know. Recent surgery. Active internal bleeding. A CVA within the last 3 months. An aneurysm.
Does that just mean regular
An
childbirth?
obstetric delivery. Yes, ma'am. Either by vaginal or C-section.
Within how long?
That's a great question. That's a really good question. I don't know. I wonder if it's 3 months like the CVA or recent surgery. I would have to look that up.
What's a CVA?
A CVA is a cardiovascular accident, which is a ischemic stroke or hemorrhagic stroke. Next on the list is organ biopsy. Next is a recent GI bleed. Rupture of a non-compressible blood vessel. Recent major trauma. Known blood clotting defects. Uncontrolled hypertension. Liver disease. And anyone under the age of 18. These drugs also must be given within a very specific time frame. So if you saw Mima at 10 a.m. and she was normal, and then you went back to Mima's house at noon, and all of a sudden she had a left facial droop, she couldn't lift her left arm, and she's slurring her words, and you call 911, and the doctor says, or the EMS say to you, when was her last known well time? That means, when was the last time anyone saw her normal? Obviously, normal is a relative term. I'm talking about their baseline, okay? Differing from their baseline mentally, physically. And you say, I saw her at 10 a.m. He says, great. And then he sends Mima for a CT scan, and sees that she has had an ischemic stroke. Ischemic stroke is a blood clot in your brain. That is the opposite of a hemorrhagic stroke. A hemorrhagic stroke is a contraindication for TNK or any of these drugs. Okay? So he says, great, this patient has an ischemic stroke. She doesn't fit any of the contraindications. She is a good candidate to have tenecteplase. And she is able to receive a thrombolytic medication. Okay? Now, if you were to say, I saw Mima on Sunday and she was fine, and then I went to go check on her because I haven't seen her or talked to her, and all of a sudden she's exhibiting these symptoms, automatically she is no longer a candidate because nobody knows for 100% fact when her last known well was. I believe the manufacturer gives this a 4 to 6 hour window, but most hospital systems will only give a thrombolytic within 3 to 4 hours. Because I think they're more on the cautious side of that time constraint with 3 to 4 hours. They don't want to say 6 hours and then it actually was 8 or 12 or whatever. You know what I mean? The time constraint is very important when it comes to thrombolytics. So the indication, other than all the ones that I gave you, would be an allergy to the drug. If you saw this listed as an allergy for your patient, that means that they've received a thrombolytic before, and that means you need to look deeper into their history. Okay. Because that means you need to know why this patient has received a thrombolytic. So adverse effects are, number one, obviously are going to be bleeding. This is the biggest, hugest adverse effect for thrombolytic therapy. If your patient has received a thrombolytic, they most likely will be on bed rest for a certain period of time because they do not want this patient up and walking, possibly falling, and then hemorrhaging from a brain bleed because there is no clotting factors anymore. There is no clotting. This has completely reversed any type of clotting that this patient has for the time being. Okay. And you do not want to give anticoagulants or antiplatelets on top of thrombolytic therapy. The pharmacology instructor is talking to the student about how low molecular weight heparin, what would the instructor indicate as an advantage of these medications? So enoxaparin, which is Lovenox, is a low molecular weight heparin. There's a difference between Lovenox and heparin. And I realized that we didn't go over that. So the answer is that it causes fewer systemic adverse effects. We're going to look at the rationale. So because of the size and the nature of the molecules, because we're talking about a low molecular weight, so the molecules are smaller, these drugs do not greatly affect thrombin, clotting, or PT. Therefore, they cause fewer systemic adverse effects. So your patients that are taking Lovenox over heparin, they are experiencing less systemic adverse effects. All right, anticoagulant adjunctive therapy. This first one is Eliquis. No, it's not. Oh, I'm sorry. That's the antidote for Eliquis. This first one is the antidote for Eliquis. What is protamine sulfate? The antidote for heparin. Vitamin K is the antidote for warfarin, Coumadin. Also, prothrombin complex concentrate. These can both be used. But vitamin K is the most commonly known antidote for warfarin. This is a hemorrhagic agent. Words are hard sometimes. This can induce hemorrhage. It decreases platelet aggregation and decreases fibrinogen concentration. It decreases blood clot formation, increases blood flow through narrowed or damaged vessels, and associated with many cardiovascular stimulatory effects. This is a drug that I've never actually seen in practice. Doesn't mean it's not given, it's just not common. All right, bleeding disorders. So we have hemophilia. This is a genetic lack of clotting factors that leaves the patient vulnerable to excessive bleeding with any injury. Liver disease affects your clotting factors and proteins that are needed for clotting that are not being produced because of that liver disease. Bone marrow disorders. Platelets are not formed in sufficient quantity to be effective because they are born, I don't have a better word in this moment, in the bone marrow. So there are replacement factors for the specific clotting factors that are genetically missing in the particular type of hemophilia. Anti-hemophilic factor includes these drugs, Eloctate, Obizur, and Refacto. We have coagulation factor 7, which is Novo7. We have factor 9, which is Benefix. Factor 9 complex, which is a combination. Anti-inhibitor coagulant complex, and then factor 8. So factor 7, 9, and 8 are the most common hemophilia factors that are missing. So the point of these drugs is to replace the clotting factor that they are either genetically missing or low in because of their type of hemophilia. So it prevents blood loss from injury or during surgery, treating bleeding disorders, and is the drug of choice. Depends on particular hemophilia being treated or particular coagulation abnormalities. So it depends on what they are missing. Oh, Carly says I have factor 5. So she has a clotting disorder. She's missing factor 5. So if she were to have surgery, they would probably give her factor 5 before she has surgery. Contraindications would be an allergy, of course, liver disease for factor 9 with signs of intravascular coagulation or fibrinolysis, and lactation. This is not something you want to take while you're breastfeeding. Adverse effects are associated with the use of blood products. So what can happen when you get blood products? The most common adverse reaction, and it's an allergic reaction. Headache, flushing, fever, chills, lethargy, nausea and vomiting, stinging, itching, and burning at the site of injection. So So, factor 8 is hemophilia A. Factor 8 is used to treat hemophilia A. I feel like there was a question about hemophilia on your exam. Something about heredity. I don't remember what it is. Like how it's passed down. You know how some hemophilia is only passed to boys? I just forget which one it is. That will most likely be on your key point. It is only 2:13 and this girl is packing up ready to walk out the door. Wow. She's like, I'm getting out of here. Okay, so hemostatic agents. These were made actually because of war. These are used most commonly in the beginning, like literally on the battlefield to stop people from hemorrhaging and bleeding out. Huh?
I could like
Yes. So now they're also still used in warfare, but they're also used in the OR. We use them a lot in the OR. So we have systemic hemostatic agents. Systemic means that it's going through the entire body. Okay. Topical is going to be in a very localized spot. Okay. So we have absorbable gelatin, which is gel foam, which is like the best when it comes to OR hemostatic agents. It's really nice. It's used a lot in neurosurgery. And then we have human fibrin sealant, Artis. This is used a lot with burns. It is also used with breast reductions. And it's because Artis, this fibrin sealant, it acts like a glue. And we did, it was called, I don't remember what we call it, like Booby Wednesday or something. And we did breast reductions on Wednesdays at Akron Children's. And we would use Artis for those. Avitine is a collagen. It is also can be used in neurosurgery. Thrombin and recombinant thrombin is also used a lot in neurosurgery. So these will stop bleeding right at the site. So if you all of a sudden start hemorrhaging, they can grab that gel foam, put it on top of where you're bleeding from, and it will immediately coagulate that blood. Okay. So the way that it was found during warfare is it was like a powder, and the guys would carry this powder, and if they came across someone who was hemorrhaging from a bullet wound or whatever, and they got their leg blown off and they're hemorrhaging out of their femoral artery, okay, you're going to put on a tourniquet and then you're going to pour some of this powder on, and it's going to coagulate that blood long enough so that they don't bleed out and die, and you can get them to someone that can save their life. Okay. That is the point of hemostatic agents. It is to stop the bleeding in time for someone to physically stop it to create hemostasis. So, systemic, it inhibits plasminogen activating substances, has some antiplasm agent or activity. So remember, systemic, this is through the whole body, and the topical is going to be localized. So this prevents body-wide or systemic clot breakdown to prevent blood loss. I feel like this would be pretty dangerous to give in a systemic situation because it would probably make the blood very, very thick or viscous, which would could cause clotting in a lot of different places, microvascular clotting, strokes, DVTs, PEs. So I feel like the systemic version of this would probably be very dangerous to use. And the topical is safer because it's localized. It's not going systemic. Okay, it's not affecting your brain, your lungs, your heart. So it's for surface injuries that involve so much damage to the small vessels in that area that the clotting does not occur and the blood is slowly and continuously lost. The systemic is rapidly absorbed, widely distributed through the body, excreted largely unchanged in the urine, so it's most likely going to be nephrotoxic. And topical is available in sponges, sprays, and topical solutions. This is contraindicated. Systemic is contraindicated with acute DIC. Topical is contraindicated to if you have an allergy to bovine products. Who doesn't use bovine products? What religion does not use pig parts or eat
Muslim?
pigs? Muslim. Who? Are you Muslim? Oh. Muslim, people of the Muslim faith do not consume pig products. So they will be very against receiving thrombin products because it is made from pigs. Systemic cardiac disease, renal or hepatic dysfunction, and pregnancy and lactation. Your adverse effects are going to be excessive clotting, like I said, for the systemic. If you're giving it everywhere, you're going to be clotting everywhere. CNS effects, probably from the stroke you're going to have. GI effects, weakness, fatigue, malaise, muscle pain, intrarenal obstruction, and renal dysfunction because your kidneys are not being perfused. The blood is too thick. And then topical, your adverse effect will be infection. The indications for use of a systemic hemostatic agent is to prevent blood loss from injury or surgery and to treat bleeding disorders. Tis false. Why? Because it's talking about systemic. Yes. The systemic hemostatic agents are used to prevent body-wide or systemic clot breakdown, thus preventing blood loss in situations in which serious systemic bleeding could occur or hyperfibrinolysis. Okay, so left is chapter 49, which, I mean, with this heavy content, I'm surprised. I'm really glad that we got as far as we did. So we will finish chapter 49 Monday morning, and then we will have a review. Please watch your email. I don't want you to miss any important correspondence from me. I already sent the video from Monday. You should have already got it in your email. I know that this is really heavy material. So, I mean, really, you just have to do your best to review it, get through it, find little ways or silly ways or whatever you can do to remember those zebras. Remember those stars and things that I repeated multiple times. Reach out if you have any questions. Reach out if you need help with your math. Okay. It is required to do the math worksheet on Brightspace before your exam, or you will not be able to take your exam. Okay. Any questions? Is everyone just completely overloaded?
Yeah, I guess I had a question, and I don't know, I guess this would be like kind of up to everybody. If maybe if you were able to like just record chapter 49's lecture and we could kind of like watch it throughout the week or something. So that way we have more time than just like the day before to kind of get all of that information.
I will absolutely try. You guys have to remember that not only am I an instructor, I'm also the clinical coordinator. So I have lots and lots of hats to wear. I also am getting my master's degree and have homework to do. So, I do not usually get into the routine of providing less it really comes down to the minute of not being able to get through that content, which I did do that in the last week of last month because I had 2 chapters that I still had to get through, and it was the day before their final, and I would have rather reviewed that entire day before a final than spend 2 or 3 hours in lecture, especially when we only had 2 hours of class. So it's not something that I want to routinely get into, especially when we have an entire class day for review. So is it off the table in the future if we ever get to a point where we need to do something like that? No, of course not. I will absolutely consider that. But for this situation, I don't think it's necessary. It's only 1 chapter and it's a short chapter. So.
In regards to clinicals, I mean, it's not a problem, but why do we only have 2 clinicals this month? Like, what is the change?
It's not a change. This was the way that
This class was hard as hell.
Yeah, this course was built with only 15 clinical hours, and it was approved by the Ohio Board of Nursing for only 15 clinical hours. So all of the rest of your classes, except for those few in the beginning, have like 30, 45. A couple of them have like 60 clinical hours. But specifically for advanced Pharm, you are only required 15 clinical hours. And that is just part of our core curriculum with the Ohio Board of Nursing.
I was just curious because it was different. That was all. Thank you.
Oh yeah, you're fine. You're fine. So many of them in the beginning are 30. So anybody else? Is anybody still interested in coming to campus on Monday? If you are, I need to know ahead of time.
I kind of asked about it yesterday, but truthfully, I feel like you have done a very good job over the like online lecture that I feel a lot more comfortable in a sense. I guess I'll see after my first exam. But I mean, I felt more comfortable after the whole lesson yesterday.
Good. I'm glad you felt that way. Hey, please let me know if you need any help on your list. Okay. I would love to be able to go to Christy. I would really love to do that. So it's okay if it doesn't happen, but I will not allow any of you to fail because of math. I promise you that. I will not allow it. So please let me know if I can help you with math. All right. Please be checking your emails. You will be hearing from me. Okay. Okay.